No, no, no. You can open the pen drive. The presentation there, the pen drive one. Yes. Come down, come down. Medical. Lab one. Yes. Yes.
The PPT videos are there?
No. Don't please just open.
No, no.
Good morning, all. Thank you so much, Kgmu administration, Vice Chancellor, Dean, and the team of doctors who have invited us, headed by Dr. Rhythm, Dr. Vivek, and all the senior faculty members. So it's a pleasure, and we always consider these opportunities are really golden opportunities when we get an opportunity to interact with young minds, because this rare diseases community and their problems, as told by Dr. Rhythm, is not met or not seen for a long time. And it is high time we have to look into their problems, we have to address, and their voice also has to be heard. For that, we as medical fraternity should join together, get knowledge about their issues, and start working on their unique problems. First, I'll be talking about what is going on in genetics. As a genetic consultant, what exactly is going on in genetics. Next 20 minutes, it will be about the model syndrome we have taken today is Down syndrome, the medical and multi-speciality care needed for children with Down syndrome. There are some preventive aspects we can take, and that I'll be talking at the end of my session. So medical and behavioral considerations in children with genetic disorders with Down syndrome as a model. So my focus of interest is rare genetic disorders. I'm basically, I'm a pediatrician. I got trained in genetics. I'm practicing genetics for 14 years. So we want to achieve a society where rare diseases children live with their rights, equal rights, and also their medical needs met. That is the goal. And children or adults with special needs, birth defects, including antenatal during pregnancy birth defects, and the familial cancers. So most of you would be knowing 10% of the cancers can be hereditary. And if we identify that, we can prevent and manage these families effectively. These are my focuses of interest. Children with genetic diseases or rare diseases, special needs have their unique challenges. Not only them, their families have the unique challenges. The medical challenges or these disorders are crippling and chronic. You're not going to stop the care at one point of time. This care is going to take a long time, maybe lifelong. And these abnormalities involve multi-system. You cannot stop going to one doctor and come back. You have to run to one clinic to other to get the holistic care for these children. They are progressively worsening. So it is not the child who are seeing today. This disease is going to evolve over a period of time. This is going to add up on the challenges they are facing. So every year, the family is going to face at least 1% of additional challenges than they faced in the previous year. Most have no specific treatment, and supportive care and follow-up is available, but not uniform across India. So you cannot give one tablet, get away with the disease. They have to live with this disease for their life. And the family has to take that travel, the very painful travel along with the child. These medical care put the family into one social situation where they have to run for hospitals. The mother or one parent will be taking care of the child 24 hours. The other parent has to support. Going to a doctor, admitting a child for pneumonia, he has to take some leaves. His irregularity in jobs costs his job. And the other hand, they run from one hospital to other, paying everything. So financial and social, economical, whatever you say, they are in a very difficult situation. Most importantly, rare genetic disorders have recurrence risk. The recurrence risk can be up to even 100% in some rare diseases. Unless you identify genetically, you prove them genetically, you cannot prevent another baby being born with the same disorder in the family. Maybe the first baby would have been born, we don't know what would have happened, and suddenly it would have come out. The generation to come, nothing will be there. Suddenly one baby will be affected. That you can pardon yourself. You cannot pardon a baby being born in the same family with the same genetic disorder. That means something has gone wrong. We have missed something. So that situation is always there for this rare disease community. We would have heard about social distancing during COVID era, but these families are facing social distancing from the day the baby is born. You cannot see them in any public festivals or even family gatherings. That is not because of them, that is because of the society. They don't want to face the society with these children. So early diagnosis is important because before an irreversible change occurs in the child, if treatment options are there, we will try to get it for the child. For that, we have to make an early diagnosis. There are studies which shows, these are proven studies which shows the average time taken to fix the genetic diagnosis in a rare disease is around 7 years. 7 years is a too long period. We cannot cope up after that because irreversible damage has happened. The diagnostic odyssey can be significantly higher in some complicated cases as well. So what if you diagnose a syndrome? We know that when the child is entering into our room, that this child has features of Down syndrome. Why should I check it and prove it? What is the use? You are giving an answer to the family. That gives a big relief to the family. Their big pain is, I've gone to all the hospitals possible. No doctor has told me what is going wrong with my child. That gives more pain than you telling them black or white, this is possible and this is not possible. Treat, support, and manage. All these are possible only with a genetic diagnosis. We should have an unquestionable diagnosis with a baby. So preventing and further complications. A child with Down syndrome can develop a hypothyroidism. Unless you prove that this child has Down syndrome, you will not look for thyroid abnormalities. So you are leading that child into another complication called hypothyroidism. Same way, in future pregnancies, to prevent a baby being born with same disorder, we need a genetic diagnosis. With that, we can do prenatal testing by amniocentesis or chorionic villus sampling and identify the baby is affected or not. And provide support to family and the child by support groups, because doctors cannot give all the solutions. You can treat the family medically, but they need social support. They have to flock together. They have to go talk to policymakers. At least they have to talk their struggles, their sorrows, their pain amongst themselves. We don't have time to listen to all these. They may not open up to doctors. So this Down Syndrome Federation of India is a successful organization running in India, not only in India, across the globe. And they are doing a fantastic work. Same way, there are so many family support groups of coming up. So once we make a genetic diagnosis, we get them registered in these support groups so that they gather together, make some noise, make these policymakers change these policies. They get all the needs, unheard needs of them. Most importantly, recurrence prevention as a geneticist point of view, it is 100% possible. Whether you treat a child with genetic disorder or not, it depends on the severity of the disease. But whether you can prevent the disease or not is in your hands. If you make a genetic diagnosis, make a prediction, recurrence risk prediction, plan the next pregnancy, give prenatal advice for them, do prenatal testing, and you can prevent babies being born with genetic diseases. So risk determination, carrier screening for the parents, preventive options like prenatal testing, pre-implantation genetic diagnosis, donor options can be offered, and we can strategize the future pregnancies. Treatment options for genetic disorders, most importantly, we can give supportive care. If you don't have one treatment, one medicine to cure a disease, that doesn't mean you have to give up on the child. So these children can improve with multi-system supportive care, anticipatory guidance, and prevention of further complications. Neurodevelopmental delay, for example, there are rehabilitative measures like physiotherapy, occupational therapy, and if the baby has seizures, we can control seizures. So ongoing encephalopathy can be prevented. Cardiac abnormalities, we can do surgeries very successfully now, and medications also can treat. Same way, there are so many treatment options. A child with inborn errors of metabolism can be effectively managed with diet therapy itself. Taking away the offending protein can improve the child. So avoiding specific foods, for example, in G6PD deficiency, phototherapy itself is a treatment in some genetic disorders, growth hormone treatment, bone marrow transplantations, liver transplantations. There are some medications like nitisinone, pancreatic enzyme supplementation, cystic fibrosis. All these are considered treatments only. But they are not going to change the gene, but they will definitely give improvement. Enzyme replacement therapy is the middle intermediate therapy we look for. One gene is mutated. Because of that, one protein is not produced. That protein can be a hormone, can be an enzyme. So because of this absence, there are cellular manifestations at various levels. So this enzyme replacement therapy is giving that intermediate one, the enzyme. Gene is mutated, enzyme not produced, I am giving that enzyme. That is available for few of the lysosomal storage disorders. These storage disorders constitute about 50 and odd diseases, amongst which these disorders we have treatment options like enzyme replacement therapy. This can be given 15 days once, and these children can live lifelong without any complications when we are able to give this. A child 2 years old with Pompe's disease is receiving enzyme replacement therapy called myozyme. And most importantly, the cost is too much. So for a child weighing 10 kgs, if I need to give myozyme for a year, it will cost around 60 to 80 lakhs. And I'm giving this based on the charity only. So the company is giving this medication free of cost for this child. And not only that, we've tested the next baby for the genetic disease of the previous baby. The next baby was found to be normal. So they have a normal child. They have a baby with a genetic disorder with treatment also. All these can be achievable if you make a genetic diagnosis. Another child who's studying B.Com now, he is receiving enzyme replacement therapy past 10 years. His disease is called Gaucher's disease, and again, charity access program. Without this, he wouldn't have survived. He is suffering from Gaucher's type 3 neuronopathic Gaucher. He is getting this treatment. Like he will come. Actually, now he is coming to get the enzyme. He will come, take that enzyme, get it infused and go 15 days once. So this is possible. So there was an charity accessible program previously, but now it is not there. Now there are some options like ESI beneficiaries. Government is giving 50 lakhs for a child under rare diseases fund. Sometimes we opt for crowdfunding. Some way we have to get the medications. We have to try all the sources possible. The ultimate therapy, that is changing the gene, is possible with gene therapy. So you would have heard about Duchenne muscular dystrophy, spinal muscular atrophy. The spinal muscular atrophy gene therapy costs 16 crores. And we have done it. A child from a middle class family, they have collected 16 crore medication. Across Tamil Nadu, this was a sensation, and everybody donated, and we gave the gene therapy. So crowdfunding, a sensation is created, they will give. Each and every time, if you go with a SMA child, they will not give. Second and third child, they didn't give, we couldn't collect. So these possibilities are there. The medications are from abroad. So in India, the accessibility, the affordability is very less. And we have a child with SMA who is getting oral medication. This is called risdiplam, and this is given again as charity. So most of our patients, we have to apply somewhere, get these free medications. If we cannot get free medication, we'll give them supportive care. So challenges in management, real challenge of managing rare diseases lies in the management. We can make diagnosis, we can prevent, but again, management is very, very difficult. The hurdles are late diagnosis, that slowly it is picking up. Most importantly, now access to medications and the affordability. Delay in diagnosis, remember, can cause irreversible damage. So for children with Pompe or Gaucher or SMA, whom I've been telling, if the diagnosis is delayed, irreversible damage, how much ever enzyme replacement therapy you are going to give, the child is not going to improve. So gold standard treatment like enzyme replacement therapy or gene therapy is very, very difficult, not accessible to Indian patients. Now patients are traveling abroad to get these medications. You would have heard about some stories in your childhood. Father who's trying to save his girl child whose life is hidden in a place. He has to cross 7 seas, 7 mountains to get that life of his daughter. This is happening in real. A medication called risdiplam costs around 6 lakhs a vial. And every month they need 2 vials at least. This is available at 50,000 rupees in China and 25,000 in Pakistan. These parents travel to these countries, get registered there, get medications for at least 6 months, come back and give these medications. All these are happening in gene disorder families. This is happening in real, happening in the families, and the families are devastated. So creating awareness is the role played by us. We have to take care of these families. More than that, we have to come out, talk to our fellow professionals, make them understand these are happening in the genetic field. We have to go talk to the public. We conduct continuing medical education programs, EMEs. This is our health minister. I lead our patients to health minister. We give all the needs in a letter, and we conduct marathons. We get support from senior actors like Karthi, director Ram. They all come out and talk for as ambassadors. We conduct camps, and we talk in social media, and we conduct symposiums along with doctors. The families will be sitting here, doctors will be sitting here, and a symposium will be conducted so that exchange of the problems and the solutions will happen at one place. We write letter to chief minister. All these I'm actually running a YouTube called Marabonu to create awareness. So creating awareness is in our hands. That is again is our duty. So awareness is better, but diagnostic modalities are better. You name any genetic testing, it is available in India nowadays. Preventive strategies are improving. Supportive care is not uniform. This is what I want to emphasize. The supportive care, I say a child with neurodevelopmental abnormality, physiotherapy, occupational therapy, multi-system, you have to monitor. This is not uniform across the hospitals. Even in Lucknow, if you take 4 hospitals will be having different protocols. So that makes their lives even more difficult. And treatment accessibility is very painful to say. We are in a very bad situation. So I'm looking forward in the future with hope. Some Indian Research Institute will bring us some generic medications like they brought Covaxin to us. So we are looking for generic medications from local manufacturers for these children. But again, with all these difficulties, our fight will continue to manage these children with rare diseases. So first topic, I finished. I'll move on to Down syndrome. This is a role model we will take for today. This is an event along with our India International Down Syndrome Federation event. We are continuing this. So I'm taking Down syndrome as a model, and it is an ideal model to discuss among students. So why it is called Down syndrome? Because an English physician diagnosed this syndrome, and he actually collaborated, or he collected all the data, why these children are looking alike, why they are having same characters, and then he brought everything under one term. This is one genetic disorder. And in 1959, it was identified as chromosomal abnormality. Previously itself, it was defined as one group of disorder, but again, later on, they found out the cause. And in 2000, they identified genes responsible. There are extra genes in the chromosome 21 because there is an extra chromosome, and there are 329 and odd genes which are there, which causes the abnormality. So where exactly the problem lies? This will explain the genetics of your body. So we stand as a human being, and if you split our body, organs, tissues, cells. Inside cells, inside one cell, there will be one nucleus. Inside this nucleus, there are 46 chromosomes, 23 from father, 23 from mother. So 23 pairs of chromosomes. These are like bricks. 23 pairs of bricks are there. Inside these bricks, there are 23,000 pairs of genes, single genes. These are the signal producers to our body. So chromosomes are just containers. There are 23 pairs of bricks, 23,000 granules inside these bricks. So the chromosomes are containers, 46, 22 pairs of chromosomes, 2 X and Y chromosomes. Okay. So there can be problems in the containers. It is called chromosomal structural and chromosomal numerical abnormalities. So containers, if one container is extra, that is a numerical abnormality. Instead of 46, there is another extra chromosome. It adds to 47. One container is more. And if there is a structural abnormality in the 46 chromosome, there is some breakage, some chip of brick is missing. Some granules are lost, some genes are lost. This is called structural abnormality. So the topic today is Down syndrome. Here the abnormality is at the 21st locus. So here you can see there are 3 chromosomes instead of 2. So there is an extra brick with extra genes. The gene count is 329 granules are there in this big brick. Structural rearrangements can be translocations, one chromosome sitting on the other. There can be breakages called deletions. There can be duplications. All these are structural abnormalities. Though, so this is a child. Can you identify what the problem is? Simple logic, relate to our topic. So child with Down syndrome, obviously. Okay. So there are features, upslanting palpebrals, flat facial profile, hypertelorism, round faces, all these are there. But again, you know the diagnosis is Down syndrome. What can be the genotype? What can be the genetics? What will the karyotype look like? Do we need to confirm this with karyotyping? Why? Let us see why. So what will be the genotype? This is a question. Obviously, there should be an extra chromosome, 21st locus. But there are three types of genetic abnormalities. That is non-disjunction type, translocation, or mosaicism. This has clinical implications. If you see here, where is an abnormality? Arrow mark is given. So 21st locus, 3 chromosomes, trisomy 21. This is the problem. This is called non-disjunction type. This constitutes about 95% of the children with Down syndrome. So 95, 10 out of 100 children, 95 will be having this one. This is called a accidental trisomy. This is purely because of an accident happened during meiosis, during the splitting of the gametes. This has happened. This is an accidental event. This doesn't have any family recurrence or any family reflections. So this is not hereditary. So next thing is, what is this? A child with Down syndrome, the same picture, the child has had this karyotyping. What is the abnormality here? The child has Down syndrome. If you see this 21st locus, this is the 21st locus, there are 1 and 2. But I'm sure the baby has features of Down syndrome. There is an extra chromosome that is sitting on 14th chromosome. This is called translocation. Why is this important? This constitutes about 3 to 4%. Why is this important? Because this can have carrier status in the family members. A carrier parent's karyotyping will look like 21st chromosome, only one is seen, the other 21st is sitting here. For him, the chromosomes are in 21st locus is only 2. But again, when the baby turns out to be having trisomy 21, because there are 3 copies of 21 chromosomes. So parental carrier status can be there. That means this can have recurrence in the next pregnancy. So another child, same picture, Down syndrome, but the karyotyping is like this: 1, 2, and 3. The third chromosome is sitting on the 21st chromosome itself. This is called again translocation. This translocation, the character is here. The mother is carrying 21 over 21. 121 is sitting on the other. So why is this important? Because to predict the recurrence risk. Mosaicism is 2 groups of cells in the same individual. Maybe 30% of the cells will be normal, 70% will be having trisomy 21. So to predict the recurrences, this is very important. So once you know the karyotyping only, you can predict whether the next baby is going to be having trisomy 21 or normal. So pure trisomy 21, the recurrence risk is low. If you see these translocations, the recurrence risk goes up even up to 100%. So if you know the genetic makeup, you can prevent recurrence. So any child with chromosomal abnormality, Down syndrome, do a karyotyping. If it is translocation, do parental karyotyping. Parents are normal, don't worry. Parents have reflections of this. The recurrence is high. We have to offer amniocentesis or chorionic villus sampling in the next pregnancy. So as pediatricians, we go for resuscitation. And we see a child with Down syndrome. And in the newborn period itself, sometimes we can pick up. And once we have made the diagnosis clinically, how to reveal. So the parents are waiting outside. They are actually they are ready for a surprise about their offspring. They've waited for 9 to 10 months. And what you are going to do is you are going to pop off all their dreams. Okay. So when and how to reveal, what to say about the brain growth, how fruitful the offspring is going to be for the family. How am I going to take care of the baby? How am I going to counsel, first of all, optimistic or pessimistic? All these will go on in your head when you are in the operation theater, when you have received a baby with Down syndrome. Remember, this may be a fantastic diagnosis for you, but may not be for the family members. So first thing is we have to understand this is a multi-system abnormality. Each cell in your body has extra chromosome, the 21st chromosome. So each cell has 329 extra genes, and these genes are going to have their say on your body organs. So first thing is central nervous system. Most of the time they have global developmental delay, but most importantly, you can manage this with early interventions. You know that there will be a delay, but if you start early interventions like physiotherapy, occupational therapy earlier, and speech therapy earlier, they can catch up. So it doesn't mean that Down syndrome baby cannot do anything. They can do, but there will be a 20% gap. We are going to fill up that gap between them and the neurotypical children. So seizures can be associated in 9%. Autism spectrum disorder is a worse combination, but that again can be managed. And they may have behavioral disorders, but again, these are manageable. And depression and Alzheimer's, early Alzheimer's disease are common for these children. So central nervous system perspective, they will have some developmental delay, but they can catch up with your early interventions. So the idea is put these children into normal conventional schooling at 5 to 6 years of age. For that, the child should be ready. So we have to make them walk, and this is going to happen definitely without any major structural abnormalities like cardiovascular system. Most of these children, they walk by 2 years. With interventions, they walk by 1.5 years. They will have struggle in speech, but again, that has to be concentrated, and we can improve speech by speech therapy. And you can make the child talk, respond to the commands, respond to the questions, and get them toilet trained. All these are making these children ready for the school. And this is possible with children with Down syndrome if you start early interventions. So cardiac abnormalities you have to look for are, most importantly, congenital heart diseases. So most common is atrioventricular septal defects, ASD, B.E.S.T, all these are also common. So whenever you see a child with Down syndrome, think of heart, whether the heart is normal or not. Before taking a big intervention procedure, make sure the heart is normal, no congenital heart disease is there. So echo is a must, and these can be managed. Surgical options are there. Most of our children are doing very well with surgery. Obstructive sleep apnea and recurrent pneumonias are common. So obstructive sleep apnea has to be looked for before doing any procedures, like major procedures like your anesthesia and general anesthesia. So you need to know the pulmonary function test, whether it is proper or not, before planning these things. So sinusitis, nasopharyngitis, all these we manage. Endocrine abnormalities, we always look for hypothyroidism. 30 to 40% of our children with Down syndrome have endocrine abnormalities, particularly hypothyroidism. So look for thyroid abnormalities. This has to be repeated every yearly once. And whenever we find there is some issues with the thyroid, it has to be treated properly, because this is a bad combination. Down syndrome, they have 20% lag. And with hypothyroidism, their developmental lag will be still more. So we want to prevent that. Early diabetes mellitus is common. Obesity is very, very common. Vitamin D deficiency also has to be looked for. That also will be checked every year. So common abnormality we always think of in children with Down syndrome is hypotonia. So whether the tone is loose or not, I just want the muscles to work. If the child is walking well, sir, my child is walking, but the hands are not stiff. It is like dangling in the wind. I want to correct that hand. Not needed. Concentrate on muscle strengthening. All these are there. But again, if the child is able to walk, I know the muscle power is good. Of course, they can lead on to dislocations that has to be looked for. So every year, minimum yearly once, they have to go for a checkup, do thyroid profile, do cardiac evaluation if needed, maybe head-to-toe examination, developmental assessment. All these has to be mapped, and one person has to be a leader, team leader, guiding these children to various departments when they have complications. So they may have scoliosis, they may have joint dislocations. All these has to be actively looked for. Most of these are preventable with physiotherapy and interventions. And if they happen, it can be corrected also. So they may be born with major intestinal obstructions that may need surgery, but that is not quite common. 10 to 20% of the children will have. And over a period, they will have this malabsorption syndromes like celiac disease. And your department, delayed tooth eruption and periodontal disease are common. Dr. Nidhi will be elaborating to you about this. So in hearing and vision, we check these children for regularly for vision abnormalities. Particularly, they are prone for myopia. So every year they have to be checked for ophthalmic evaluation. So we'll tell the family, mark 1 month, maybe the birthday month of the baby. Do all the checkups at that month. Finish off everything. and then you get an advice and follow that for a year. So most of the time this works well, and they are prone for recurrent ASOMs, that is suppurative otitis media, regular infections in the ear. This, because of this, they may have acquired hearing loss. That will be checked every 3 years once. So other abnormalities can be managed. So the dreaded complications are like leukemias. They are prone for leukemias. We check them clinically. We do complete blood counts, peripheral smear, head-to-toe examination, looking for lymphadenopathy, hepatosplenomegaly. All these will be looked for. And cutaneous abnormalities, skin abnormalities are common. Infections, they are prone for infection. So we complete all the vaccinations, and yearly influenza vaccination is strongly advised for these children, so that you can bring down the incidence of infection in them. So we have a big chart like this, and we'll follow up these children according to their age, and every year. But it is this may be a initial chart, but the unique challenges of children will change over a period of time. So this is just a guidance for us. But a child with Down syndrome will not have all the features. So maybe 70% they will have all the features, 70% of the features they'll have. That we have to manage. In the future, we'll look for other abnormalities also. So it is an ongoing process. So we follow up these children for abnormalities and treat them accordingly. There are growth charts available for children with Down syndrome. We mark in that, and we have to follow up one growth chart to know the progress. We know they are prone for short stature and obesity. Unless you plot in the map, chart, you will not know whether the growth is declining or increasing. So interesting facts are they have emotional problems. Sometimes they become silent. They'll have so many emotional storm happening inside. The difficulty is they cannot tell that out also. They will be feeling so many things inside. To put it in words, it will be very difficult for them. They will be very, very frustrated at that time, or they go for silent mode. Atlantoaxial instability, because of the loose joints, this is a dreaded complication, but asymptomatically it can present. We look for that. And life expectancy, previously it was 50 to 60. Now we are successfully improving their life expectancy even up to 70, 80. 25% lives beyond 62 years as of now. By 60 years of life, 50 to 70% can have Alzheimer's disease. And early mortality is due to cardiovascular diseases. If treated properly, we can avoid that. And pneumonia, that can be prevented with proper vaccinations. So sense of children with Down syndrome, they're very, very friendly. So today morning, I was walking, and I saw a child. Before I say hi, he said, "Good morning, uncle." So they are more proactive. They want socialization. The problem here is most of the society people don't know how to handle them. So the moment they reach to them, they will be either panic or they don't know how to handle these children. So over a period, they get into that groove. After that, it is difficult to bring them back. So very friendly, appreciate that, encourage that. They are music lovers. They swim fast, and we use this for management. For instead of children with attention deficit, swimming is an option given to them. And for children with lower limb abnormalities or difficulties, pain, they can take this as a dance gracefully. You should have seen them dancing yesterday. And they are open in everything. They are literally honest. So they won't betray. They show unconditional love. I've seen so many family members, parents particularly, I've told that they would have had one child with Down syndrome, other one with a neurotypical. They'll say comparing, we don't encourage. But again, they say comparing these two children, they'll say this child gives unconditional love. Whatever I do or not do, she is there for me or he is there for me. Unlike neurotypical. We are neurotypical, we are not like that. So we show only conditional love. So they are real God's children, and we are actually corrupted. So this is about multi-system management. Ultimately, head to toe, they need care. But everything is mapped and given to you, what has to be seen. Only meticulously, we have to look for these complications, try and avoid these complications, handhold them, take them to their future in a better way. That is possible, very much possible with children with Down syndrome. So this is a advantageous model to talk about, because there are so many other genetic disorders where I cannot offer treatment even this much. These children do very well. So they are one successful model of a rare disease or a genetic disorder. So I'll touch upon this preventive aspects of Down syndrome, because most of you or youngsters, the common situation faced is pregnancies in your families. You'll get some questions regarding reports. So Down syndrome is a common genetic abnormality, but it is mostly accidental. It happens in 1 in 600. That is the incidence. And these children will survive and will live with us. And most of the Down syndrome children will have this accidental genetic abnormality. So it is not an inherited disease. 95% and more, it is not an inherited disease. If it is a translocation trisomy 21, the recurrence is high, we have to prevent. And we will take a family who are in who have approached us, their family member or somewhere they've seen a child with Down syndrome, they're planning pregnancy and they are worried, anxious. They want to prevent a baby being born with Down syndrome. If you want to do a gold standard testing, this can be done by karyotyping, fetal karyotyping. This can be done only with chorionic villus sampling or amniocentesis. These are invasive testings. You have to go prick that amniotic membrane, take the amniotic fluid, do the testing in the fetus. So this involves 0.5% abortion risk. So most of the time, country like India offering a fluid testing for every woman is practically impossible. So these screening tests are devised. These screening tests are done basically from the mother's blood. With the biochemical evaluation, we split these families into high risk and low risk. We do certain biochemical screening tests in the mother, take blood of the mother, read the blood, and filter them into high risk category. So these high risk mothers alone will be offered invasive testing, and the confirmatory testing will give us that invasive testing will give us whether the baby is affected or not. So this is the filtering method is called Down syndrome screening. So age related risk is a previous observation. If elderly women will get child with Down syndrome. It is not true, because even young mothers are at high risk of getting a baby with Down syndrome because of their fertility percentage. Their fertility percentage is very high. If it is 1 in 600, it is not 1 in 600 for elderly mothers. It is 1 in 600 in the society. So even young mother is prone to get a baby with Down syndrome. So all the mothers has to be offered Down syndrome screening. And there are so many screening methods available. I will tell you about two screening methods which are very popular, which has to be considered. One is in a low risk women. The common one is NT and FTS screening. That is nuchal thickness and nuchal translucency and first trimester screening. This first trimester screening involves two parameters, PAP-A and beta HCG. With this, we can calculate the risk. If the risk is below 1 in 250, that is considered high risk. 1 in 249 is considered high risk. And in 1 in 251 and above is considered low risk. So with this, we have to proceed with amniocentesis and then confirm. This anti-FTS carries around 85% detection rate. This is one simple method or a cheaper method which have bigger detection rate, higher detection rate, 85%. All other screening like quadruple screening, triple screening are inferior to anti-FTS first trimester screening. So from our side, we will suggest do anti-FTS that costs around 2,500 to 3,500 rupees. Okay, the family is not happy with that 85%. They want a better detection rate. The better detection rate test is called NIPS, non-invasive prenatal screening. This is again taken from the mother's blood. Fetus cells in the mother's blood will be filtered and the genetic analysis will be done. So this detects about 99% of the babies with Down syndrome. So this has a highest detection rate. So the cost is around 10 to 15,000. So the cost is high. These two tests can be offered. In case the family wants 100%, then you have to go for chorionic villus sampling or amniocentesis, do fetal karyotyping. So for any mother who's at low risk, young age, not affordable, maybe anti-FTS, first time screening, double marker can be advised. And affordable patients or at high risk mother, 35 years and above, I'm conceiving, or they are very anxious, they want higher detection rate testing, NIPS can be offered. Leave all the other tests. Don't worry about other tests. So double marker or NIPS, higher one. And then if needed, these screening tests are just screening tests. That doesn't confirm that baby has Down syndrome. Say, for example, double marker shows 1 in 240 high risk, That means 1 in 239 children are normal inside, and only one baby has Down syndrome. The percentage works to less than 0.4%. So remember, these screening tests are not confirmatory. Don't take decisions based on these screening tests. Confirm with amniocentesis, even if it is NIPS positive, confirm with amniocentesis and then take a call. This is regarding preventive options available. Taken? Nidhi? Taken? Okay, so we'll move on. So screen positive testing options are, if the screen positive, it means 85% possibility or 99% possibility. You have to confirm with amniocentesis or chorionic villus sampling before taking decisions like termination of pregnancy. So aneuploid is proven. So a young mother has come, we've done screening, it showed high risk for the babies with Down syndrome, and we have confirmed this with amniocentesis, and fetal karyotyping shows trisomy 21. So what to do now? What will you tell them? Don't read that. What will you tell them? Go abort. No, that is not the answer you have to tell. You tell them this baby has got Down syndrome and it is your decision to continue or not. Okay, there are two reasons I will tell you. One is a mother who's suffering or struggling with infertility would prefer to have a baby with Down syndrome rather than struggle with infertility. So we have seen so many occasions. Every year, at least 3 to 5 mothers have told us, let us continue with the pregnancy. We will make sure the baby doesn't have a major organ abnormality like intestinal obstruction or major cardiac defect, which is life-threatening. So there we can say pessimistically, we can tell them, no, it is not possible. Better avoid. If the baby is clean, these abnormalities are not there, and the family is keen, we can allow. So non-directive counseling, we shouldn't guide them. They have to take a call whether to continue the pregnancy or not. Yeah. So informed decision making and non-directive counseling, we have to respect their preferences. Another group is because of religious reasons. They may not be willing to do termination. That also has to be respected. Multiple recurrence, and if it is happening because of translocation, we advise donor program, pre-implantation genetic diagnosis. But again, if it is proven, leave the decision to the family. Let them decide. There are some voices heard across the globe, voices of children or adults with Down syndrome. They are coming out and saying, we have all the rights to live. Why are you terminating us? Who gave rights for you to identify and terminate us? So these voices also has to be considered. If this is louder and the international society is listening to them, maybe this will go pointless. So these are some of the viewpoints from my side I wanted to share with you. If there are any doubts regarding this, I'll be happy to answer. Thank you.
Uh, Thank you, Dr. Pradeep, for such an insightful talk. And I'm sure the dental students who are here, they must have this knowledge in the background whenever you are dealing with such patients, because now you know that they might have come to you with just the dental problem, but you should know in the background the multiple medical problems they are having in their body, and you have to plan your treatment accordingly based on that knowledge also. So thank you, Dr. Pradeep, for giving us all that beautiful insight. And I now invite uh, Dr. Anil Kumar Jha, sir, to please come and felicitate our speaker. And I also invite Dr. Suleiman sir, Dr. Rakesh sir also to come forward.
This is the presentation which was made by a BDS final year student of our college, Ankit, Dr. Ankit.
ये काम अच्छा है।
Thank you all. Now we will leave for a short tea break and we will reassemble after 15 minutes for the next session. Thank you. We will be reassembling in 10:45, okay?
The second child is also being
This 95% non-intelligent type, you try them 1, 2, 3. Correct? So they don't need to worry about that.
कैसे करना है या फिर लैपटॉप नहीं लगेगा कैसे करना है ट्रांसफर कैसे करना है क्या करना है क्या करना है बहुत कुछ लगा हुआ है करो ये इसमें तो पूरे वायरस ही करो
कल जो आपने दिया सॉरी जो काटो मत मिनिमाइज ये है तो सबसे ऊपर नेक्स्ट ऑप्शन मत करना सबसे ऊपर वाला ये काम कर उसको उनके एक और हरी चीज निकल जाएगी
एमबी तो व्हाट्सएप पे चली जाएगी ना
एक सेकंड सर यहाँ पे हाँ मेल पे दे दी
रवि का है?
नहीं मेरा
आपका है नहीं मेरी नहीं होगी मैंने भेजी नहीं ना इसमें मेरा लग जाएगा क्या
हियर हाय
मैंने भेजी
पेन ड्राइव में
हाँ पेन ले पेन ड्राइव पेन ड्राइव मेरा काम नहीं है ये पे नरम हो तुम क्या कर रही हो पहले कंफ्यूज मत करो तो जाने नहीं कहाँ इस बच्चे को बोले कि वहाँ एक नानी और एक कॉल चेयर करते हैं कोई बात नहीं आप चेयर पर्सन को बुलाओ कि चेयर पर्सन को आगे करने को सारी चीजें हैं तो चेयर पर्सन को नहीं करना आप सर दे दो लैपटॉप लगेगा नहीं सर लैपटॉप
Welcome back, everyone. Moving on to the second section, I would like to invite Dr. Amit Arya sir, professor in the Department of Psychiatric, for introducing our guest speakers.
A very good morning to all of you. At the very outset, I'm very thankful to the organizers for inviting me in such a wonderful program, which is on multidisciplinary approach toward the special need kids and focus on dental needs. So in this important session, we are going to have speakers from various fields. First speaker is Dr. Vivek Benz. He is professor and head Department of Periodontology, Saraswati Dental College and Hospitals, Lucknow. He is a BDS from Patiala. He did his MDS in periodontology from Government Dental College Hospital, Patiala, then did his PhD. He has a PG diploma in health and hospital management with distinction. He had done certificate course in healthcare waste management. He is associate fellow in laser dentistry, World Clinical Laser Institute. He is member of National Academy of Medical Science, EC member, Indian Society of Periodontology. He has authored several books and contributed to several book chapters. He has over 1,700 citations in Google Scholar. He has served as editor in Asian Journal of Oral Health and Allied Sciences. He is guest speaker at national and international conferences, chair, member of committees on research ethics, internal quality assurance. He is active participant in CDE programs, seminars, and scientific workshops. So, I mean, he's the one person who can speak a lot. We are here to listen to his expertise and gain from his wisdom. So I welcome Dr. Vivek Benz for his presentation. Sir.
Thank you, Dr. Arya. Good morning, everyone, and thank you for the wonderful introduction. Let's start. The question is why I'm here. Imagine a Down syndrome patient, age of 40 or 30, almost edentulous. All teeth extracted majorly because of periodontal reasons. So I'm here to tell you that Down syndrome is most common genetic disease. Already discussed this part. Nearly 100% of Down syndrome personals under age of 30 have periodontitis. Life expectancy, already told you, it's increased, means more number of years of periodontitis. Periodontitis is highly prevalent, severe, generalized, and rapidly progressing in Down syndrome, and we will discuss this why it is so. And although local factors like plaque are present, but they alone do not fully explain the severity of periodontal disease. That's why we are going to discuss this part. So let's discuss periodontal consideration in Down syndrome. I will try to go through my slides for 15 minutes. This presentation is a compilation of the review of literature, and all the figures and all the literature has been taken from the public forum. And if anybody sleeps, then it is not my responsibility. Before discussing about the periodontal consideration, I would like to tell you about periodontitis. So periodontitis is a chronic biofilm-driven inflammatory disease of the gums where dysregulated interaction between oral bacteria and host immune response causes progressive destruction of the periodontium. And it is an imbalanced interaction between the local microbiome and inflammatory response of the host. And it is characterized by the inflammation, gingival inflammation, pocket formation, clinical attachment loss, bone resorption, mobility, and eventually tooth loss. And if untreated, the disease can lead to tooth loss, compromised mastication, aesthetics, and quality of the life. So this is a diagram showing the role of periodontitis. And if you see this diagram, it is not only the dental condition, it is the inflammatory markers, it is the inflammatory cytokines that are poured into the circulation and hence affect the entire body. That's why it is important to understand the pathogenesis behind the periodontitis. So already discussed about the Down syndrome. It is the Mr. Down who actually in 1966 observed the condition. And if you read the history of Down syndrome, it is interesting. And only it's 1965, yes, when the name was changed from Mongolianism to Down syndrome because of objections. Basically, the Down syndrome people have intellectual issues, systemic issues, and the facial problems. And if this is the, we can say, various clinical symptoms which can be seen in the patients. Now, let's discuss about the prevalence of the periodontal diseases in Down syndrome patients. Almost 100% of all the cases of Down syndrome suffer from periodontal disease. Institutionalized patients are more prone to periodontal disease as compared to those who are getting care at home. And it appears that the lower anterior together with the upper molars are the first affected with these with the conditions. So if we see the Down syndrome, there are local factors like developmental defects, oral and microbiological defects, salivary abnormalities, poor oral hygiene, and systemic factors like dysregulated innate immune, dysregulated adaptive immune response, elevated inflammatory cytokines, and increase in the MMPs that may result in destructive condition. The factors contributing to the periodontal disease in Down syndrome, these are non-specific endogenous factors, and there are specific systemic factors, and there are also non-specific local factors and specific local factors. First is the vascular abnormalities. It results in inadequate circulatory system, anoxia, the lack of oxygen to the tissues, then resulting in diminished blood supply, and abnormal capillary fragility also results in severity of the disease. Further is a connective tissue disorders are there, that is increase in the collagen synthesis, but there's a block in the collagen maturation. So collagen is increased, but it is not matured properly. And further, breakdown of the mature collagen is another reason for increased periodontitis. Further, there are thymus abnormalities like structure abnormalities and the calcified Hassel bodies that results in atypical T-cell immunodeficiency in Down syndrome patients. So these people have immunological dysfunctions. They have abnormalities of cytokines, innate and adaptive immune response in Down syndrome that actually aggravate such conditions in Down syndrome patients. There are specific endogenous factors like humoral immune response defects. There are cell-mediated immune response, and there is diminished delayed hypersensitivity response in such individuals. Further, institutional stress is also responsible for their aggravated condition or periodontal conditions that results in that affects the T cell function in the body. Beside that, there are non-specific exogenous inflammatory factors also present. Like primary factor is the plaque and difficult oral hygiene, or you can say inability to properly maintain oral hygiene is the basic reason. The important point, the amount of plaque deposited in the oral cavity does not commensurate with the severity of periodontal disease. So these patients may be having less amount of plaque or calculus in the oral cavity, but the response of the body will be severe. So there are arena of, you can say, various types of the defects. You can oral defects, malocclusion, bruxism, lack of lip seal, enamel hypoplasia, crowding, mandibular prognathism, hypoplastic maxilla, narrow palate, macroglossia, open mouth breathing, then the hypertonia. All these features actually increases the chances and the severity of periodontal disease in such patients. And beside that, there are specific exogenous factors also. Taurodontism can be seen, short roots. All these lead to further early tooth loss or early periodontal involvement. Beside that, reduced salivary flow rate, altered salivary protein lipid ratio, and fissure tongue with macroglossia. Again, it make a favorable environment for periodontal pathogens to survive in the oral cavity. Now let's discuss what is the impact of intellectual disability on Down syndrome periodontal health. There's an impact because of limited self-care skills. These patients lack limited self-care skills unless until they are actually, we can say, trained for that. Then dependence on caregivers, most important point just discussed by Dr. Sab also. Lack of motivation because of lack of awareness, because they're not aware. That's why their motivation is less. Then further, attendance in the dental clinic and preventive care is totally dependent on their caregivers. So unless until caregiver is understand the issues, their attendance in the dental clinic will be less. Further, intellectual disability that limits their ability to report the symptoms. They may not be able to properly report what the symptoms in them. Then there may be difficulty in behavior, specifically in the dental clinic. Then there's a burden by the caregiver because they are mostly dependent on the caregiver for their understanding. Therefore, the knowledge of the disease and their symptom in the caregiver is more important than their own self. This all cumulative effect results in inadequate plaque control, irregular follow-ups, the reduced self-reporting symptoms, and further, it all results in reduced quality of life. The quality of life is actually reduced. So what we can do, we can educate, and training of the caregiver can be done. Modified toothbrushes, electric toothbrushes, pictorial, oral hygiene charts, and supervising brushing is important. This short, simplified, and repeated instructions, regular, continuous, is very important. And preventive rather than curative is the part that is important. If you see the microbial profile, see if microbial profile, so many periodontal pathogens or pathogens are present in their oral cavity. You can see Propionibacterium acini, Salmonellas, then there are Peptostreptococcus micros, Equinella corridans, Porphyromonas gingivalis, Aggregated Bacterium Acidum comitans. The entire you can see this periopathogens are actually harbored in their oral cavity. That is why the condition is such like this. This is the condition you can see. Stage 3 or the category stage 4 grade C periodontitis can be seen. Early loss in adolescents, we can see the loss of tooth because of periodontal reasons. Gingivitis is common. Periodontal attachment and alveolar bone loss is there. Because of altered humoral and cell-mediated immune response, these conditions aggravated in such patients. So, already discussed that periodontal pathogens increase in the oral cavity because of reduced saliva and inflammatory condition, immune inflammatory response of the body. Further, microdontia, malocclusion, delayed eruption, open bite, all results in plaque retention. So, what is the treatment? As per the literature, it suggests mechanical plaque control alone is often insufficient. So that's why we need more, something more. And disclosing agent is the wonderful for the motivation for the caregiver as well as motivation of the patient also. So disclosing agent, brushing, maybe powered brushing or the altered brushing, interdental cleaning, and regular dental checkup, that is monthly dental checkup, is important. Tailored periodontal care may be required, constant motivation, and chlorhexidine dentifrices with disclosing agent may be helpful, as literature suggests that this is be helpful and shown positive results in the patients. Further, SRP in combination with ultrasonic scaling, 0.2% chlorhexidine as a mouth rinse for 1 minute, and brushing with chlorhexidine toothbrush twice daily is important. Recalled every month for scaling and prophylaxis for removal of the stains, and oral hygiene reinforcement is very reinforcement of the instruction every time is important. Further, there are antimicrobial mouthwashes also available. Fluoridated dentifrices, plaque disclosing agent, and scaling root planning may be an important regime for such patients. Then there are local drug delivery systems also. Sustained release like closed site or there are tetracycline fibers may be helpful in adjunct to scaling and root planning. Then whether there's an evaluation, non-surgical periodontal therapy is important or not. So results suggest that open flap debridement in the patients having more than 4 millimeter of pocket is important. It may be helpful. However, the post-operative care increases due to long-term duration of repair. So whether go for the surgery or not, again, is a issue. Dr. Nidhi will tell in detail how it is important or not. Then there is another issue. Due to learning disorders in the diabetes, in the Down syndrome patients, lengthy treatment and periodontal surgery under local anesthesia sometimes may be difficult. Further, because of use of systemic antibiotics, there are chances of antimicrobial resistance. Therefore, newer periodontal treatment can be tried. And few studies are there. There are few clinical trials are also there. One is such as antimicrobial photodynamic therapy. So we can use photodynamic therapy in such patients, and results are encouraging. In photodynamic therapy, we generally inject one dye into the sulcus, then a wavelength light or laser light of wavelength that can actually photoactivate that material can be applied. And this results in the formation of the free radicals, superoxide formation, and that superoxide can result in the destruction of the microorganism. Further, there is the role of melatonin, although there is no there are certain experimental studies, but human trials are still under process. It suggests not systemic use. It is 1% melatonin gel once a week for 4 weeks may be helpful. This is the trial which is right now undergoing, and we can see the result. Further, the role of probiotics, prebiotics, and symbiotics may be important, and most commonly used probiotics are lactobacilli, streptococcus, and bifidobacterium species. All these should be used as an adjunct to scaling route planning. So these are under trial. Now, what is the issue? Actually, there is a unique issue in the patients with the Down syndrome, specifically in the adults. I tell you my experience. A day before yesterday, we went to Golden Blossom to attend the this federation work conference, and on the gate we asked where the conference is going on. The person said, "वो बच्चों वाली conference." In the start of this program also, the main observation was that it is amongst children. But as we were discussing with Dr. Nidhi 2 days also earlier also and today also, that the problem in the person who are more than age of 18, what about them? She actually told us that after once that patient is, I can say that person is aged beyond 18 or 19, their oral care is not only oral care, all care are reduced. So this is the area of challenge. And this is because of, and this is more important because of immune dysregulation in such patients, increased systemic comorbidities. As patient will increase in age, comorbidities will increase, and this will increase the oral condition. Not only oral condition, quality of life. We are not talking only about the oral condition. We are talking about the quality of the life the patient or the person is going to live with. Then cognitive and motor limitations, as just Dr. Saab told us that dementia will occur in 50% of the patient at the age of more than 50 or 60. Then institutionalized versus, unless until the caregiver are important, then care of such patient is also very difficult. And the further, as the age increases, there is the pharmacy. There are many medications. The patients are maybe on medication, and those medications may further aggravate the oral conditions. That's why it is important to understand make a strategy for patient of Down syndrome in adults. So early care or the continuous preventive care, 6 to 8 week parental maintenance visit, customized oral hygiene aids, antimicrobials, and non-surgical adjuncts, regenerative therapies, newer can be used, behavior management for the adult. Behavior management for the children, we have read about that, we heard about that. What about the behavior management in the adults? Then multidisciplinary approach, for which this conference is there, for the intercollaborative approach, that is also very important. So conclusion, pancreatitis in Down syndrome is not just an oral health issue, but a systemic and a quality of life concern. Requires early diagnosis, continuous preventive care, and multidisciplinary management. Need for research, education, policy support to improve oral and overall health outcomes. Adults with Down syndrome face unsatisfactory oral health needs, especially severe, generalized, and rapidly progressive pancreatitis there. Currently, there is a policy and the research, there's a big policy and the research gap in India, specialty regarding adult Down syndrome care. With this, I end my presentation. This is my college where I've done my BDS and MDS. This is my college where I've done my PhD. This is where I'm working right now. This is my department. And this is a photograph. I'm standing with the heroes. One hero, Dr. Nidhi, Dr. Sureka, Rhythm, and Jaswinder. Jaswinder, when I met Jaswinder, he's 40 plus old, and he was topper in the mountaineering. He was topper in the mountaineering in Nepal. So it is a collaborative approach that is important. So another reason I am here to tell about Dr. Nidhi, that let's work for the cause, not for applause. So I request everyone to applaud Nidhi. Thank you.
Thank you, sir, for your enlightening and thought-provoking lecture. And we are moving on to the next presentation on physical and medical rehab consideration by A.K. Gupta, sir. And once again, I welcome our chairpersons, Dr. Amit Arya, sir, and as well as our Raju Gupta, sir, HOD and professor of Department of Pediatric Dentistry. And sir, kindly introduce our guest speaker.
So if there are any questions or comments, we can take them after the session is complete. So what a wonderful presentation, Vivek sir. I'm a psychiatrist, although I work for children and adolescent as well. But dentistry is very near to my heart. And I learned a lot from his presentation. I mean, plaque formation and management of we ignore these things. Oral hygiene and oral health is ignored in children with special need. I tend to see uh, kids with the periodontal diseases, and it is very difficult actually, because as Sarah said that they lack this uh, personal or oral hygiene care. So they require a keen observation by the parents and health professionals who are seeing them. So I tend to screen them for periodontal diseases. I refer them for for periodontics and uh, other specialties in dentistry. Now, covering the uh, aspects of dental issues and periodontal diseases across the life from pediatrics to adult by Dr. Vivek sir. The next speaker in line is a person who is head department of physical medicine and rehabilitation, Dr. Anil Kumar Gupta. Anil sir is very supportive when we, I mean, when we talk about the inclusion and equity, the physical medicine and rehabilitation come into picture. It cut across all the specialties, including dentistry. Sir is awardee Premlata Patnaik Award, Mandakini Parthi Memorial Gold Medal in obstetrics and gynecology, and he also got WG Rama Rao Travel Fellowship in Indian Academy of Physical Medicine and Rehabilitation. He is state level awardee of Officer Working for Empowerment of Person with Disability. Vice President, ex-secretary, Awadh Association of PMR, has written several articles, research articles, and book chapters. So I welcome Anil sir for his talk.
Thank you, sir, for nice intro. First of all, I would like to thank my Dr. Idam to invite me for this wonderful CME. So I will speak on physical and medical rehabilitation consideration for in disabilities, not particularly in Down syndrome. Actually, the workshop is organized for Down syndrome particularly, but I will speak. There is a lot of scope and lot has to be done in dentistry for special need patients. So to start with, there are 26 million individuals with disability in India, and 179 out of every 1 lakhs are estimated to have intellectual and developmental disability. And the most important thing, if we will not die from heart attack, most of us will suffer disability at a given point of time in our life. So we have to develop these things in our future clinic, particularly in government hospitals, Because in private setup, sometimes money is the issue, property rates are very high. It is not possible to expand your clinics. But it is our duty to expand the clinics as per the needs of especially able patients and government setups. So special needs patients, this patient has complex physical, medical, and behavioral needs, and dental treatment must be integrated with rehabilitation and medical care. So why multidisciplinary care is required? We have listened to eminent speaker from the morning. So it improves safety and quality of care, prevent complications from comorbidities, and enhance oral health and general health outcome. So my work to enhance and optimize functioning and quality of life of people with disability with physical impairments. So what are the common challenges? Physical impairment, like in cerebral palsy, patient has spasticity, lots of contracture, difficulty to visit, mobility issues, medical complications. Patient is on, patient has epilepsy, heart disease, diabetes, communication and behavioral barriers in autistic spectrum disorders, and medication side effect, as sir has told, xerostomia, gingival hyperplasia, that leads to periodontal disease too much. And rehab considerations are wheelchair accessibilities, and not every clinic is wheelchair accessible. Special dental chairs are required, which are not easily available in India. We require positioning and postural support. We need to give patient adaptive oral hygiene aids with the help of occupational therapy. And for feeding and swallowing rehabilitation, speech and language pathologist involvement is required. So pre-treatment medical clearance is very much required for this patient. Most of this patient has epilepsy, spasticity, tremors, and involuntary movements. So sometimes it is very difficult to treat the patient. And safe sedation and anesthesia planning. Most of these kind of patient will require anesthesia actually. And pain management tailored to comorbidities. And we should focus on preventive focus, fluoride, chelants, and diet counselings to prevent caries. So it requires multidisciplinary teams. Sorry if I have forgot some subspecialties of dental team, but we have required more people. But most important part is that in this team is caregiver and family. We have to educate that caregiver, because this patient has multiple issues. They has to run clinic to clinic, and every thing is time and cost consuming. So barrier to dental care for child with special healthcare needs to start with architecture. We have lots of architectural barrier in India, though Modi ji has started Sugamya Bharat Abhiyan, in which architectural barrier has to be removed from the each government building, and ramp, etc. And there's certain guidelines which are not actually followed. So if narrow doors are there, wheelchair not be there, will not reach in the clinic. There are steps and risers in step. These are a barrier. There is no space for wheelchair manipulation in most of the clinic. No space for transferring the child to the dental chair. No handrails, steep slopes. And most of the time, our staff is untrained to deal with the child with special healthcare needs. Pediatric patient, normal pediatric patient needs different handling. Dr. H.R. knows better how to deal with pediatric patient. It is, but they are special child, so they are very difficult to deal actually. So what are the functional limits in child with special needs can be due to different regions. Impairment at the oral and pharyngeal level. There may be underbite or overbite, misaligned tooth, overactive gag reflex, spastic pharyngeal muscles, involuntary tongue movement, bruxism. Another motor impairment at trunk and limb level. Patient may has dystonia, loss of dexterity, spastic upper limb. Patient, because of spasticity, he cannot take care of his oral health care. Mobility impairment. Patient cannot go to frequent to washroom for health care. Deformities, difficulty in adapting to the dental chair. And cognitive and behavioral challenges like anxiety, sensory sensitivities, and poor cooperation from the patient. So in spasticity and dystonia, cerebral palsy patient, stroke, and spinal cord injury patients are characterized by involuntary increase in muscle tone and dystonia. And this cause repetitive movements, abnormal posture, prevent the patient from opening the mouth or holding the mouth open long enough for examination. And uncontrolled body movement can jeopardize the safety of the patient as well as dental team. So we can block the masseter muscle by Botox. Uh, we have a time frame for 4 to 6 months. Botulinum toxin work for spasticity reduction for 4 to 6 months. So we can take the opportunity for dental treatment during this period. The persistent primitive reflex in children and adult can be a significant barrier. Most of the patients with neurodevelopmental disorder or neurodegenerative disease may have persistent primitive reflex. Hyperactive gag reflex can be triggered by a dental instrument. A tonic bite reflex can result in injury to the patient, caregiver, as well as to the dental professional. So we, as a dentist, we have to be careful so that we may not harm ourselves to treat the patient. So these are involuntary physiological responses that are not associated with patient cooperation. We have to be alert. So there are sometimes sensory and cognitive overload, anxiety and behavioral changes. Challenges increase with bright overhead lights, high-pitched drills, and sudden rush of water in dental treatment. So how to decrease these sensory and cognitive overload? If we treat with calm and supportive environment, scheduling at a comfortable time when you are not in a hurry, and gradual introduction of sensory stimuli. So the PMR physician optimize oral medication for the management of spasticity and dystonia. They can give strategic Botox injection for improving function in child with spasticity and dystonia, so that patient can lie on the dental chair. We can provide orthotic management for hands, occupational therapy and physical therapy for improving neck and face control. And we can provide adaptive equipment for oral health care, like nowadays for patient with limited hand function, electric or ultrasonic toothbrush are easily available on Amazon. We can prepare normal modified toothbrush handles for poor grip patients. Floss holders are available for cleaning. For dispensing aids, these are all easily available nowadays on the net. For bruxes, mouth guard can be provided. So yesterday I was searching because there were very little literature on this topic in the literature. So last year one meta-analysis was done in which they took 17 studies from the India. So this is a summary of that. Access to dental care were limited due to infrastructure constraint and lack of dentist training. I agree. When I did MD in PMR, so I was just focusing on spasticity part or whether patient will be able to walk or not. I was not seeing the patient as a whole, whether later on I realized patient has spasticity. He has spasticity in all the part. He will have the problem in eating. He will have digestive issue. He will have dysphagia, reflex, etc., etc. So dentistry is a big science nowadays, and we have a little focus on patient with disabilities on that. And caregiver and individuals with intellectual disability did not prioritize dental health, faced communication barrier, and were afraid of dental procedure. It is not their fault, actually. If a cerebral palsy patient comes to me, he has to visit multiple departments, eye, ENT, psychiatry, neurology, pediatric. So he has to, if the patient is coming from the outside, if coming from Lucknow itself, so at least he has to spend initial 6 to 7 days for a comprehensive consultation, so that his treatment can be started. So they don't think about actually dental problem, and patient is not able to tell that he is having pain. So it is important to improve preventive dental care and raise awareness among caregivers of individual in intellectual disability in India, and training dentists and incorporating special care dentistry into the standard dental curriculum will improve the SS. So key message is dentistry for special need patient is not isolated care. Must be part of rehabilitation-based multidisciplinary approach in which multiple specialists can work for the welfare of the patients. Thank you.
Thank you, sir, for your great lecture. Moving on to the next presentation, nursing care for special patients by Ms. Anjali Arora. Now I would like to invite our chairperson, Dr. Raju Kumar sir, for introducing our guest speaker.
A very good morning, everyone. First of all, I would like to thank Promila Verma ma'am for inviting me to chair this session, and Rhythm also. So without further delay, since we have inauguration lined up from 12 p.m., so I would like to introduce our next speaker of the session, who is Ms. Anjali Arora. She is presently working as a nursing faculty at Kgmu College of Working, and her educational qualifications include MSc with the Medical Surgical Nursing Gastroenterology from Institute of Liver and Biliary Sciences, B.S.C Nursing from Dr. RML Hospital, New Delhi. She is certified in critical care nursing from Sir Gangaram Hospital, New Delhi, and she is a master trainer of hepatitis and its complications from ILBS, New Delhi. She has also done several short-term training courses, including one in wound care at Maharaja Agrasen Hospital, certificate course in critical care nursing from Gangaram Hospital, New Delhi. She's also a master trainer in hepatitis and complication from ILBS, and she has done e-course in essentials of chest surgery for nurses, Medanta Hospital, New Delhi. Other than the KGME experience, she also have the experience from previous institute, including the Maharaja Agrasen Hospital, Punjabi Bagh, New Delhi, and she has also been a nursing faculty at Holy Hospital College of Nursing, New Delhi. So I invite Ms. Anjali Arora ma'am for her presentation on nursing care for special patients. Welcome, ma'am.
Thank you so much, sir, for the introduction. A very good morning to all of you. Today, I'm going to present a topic based on the nursing care considerations for the special patients such as Down syndrome. As we know that the Down syndrome is a genetic disorder, right? And this genetic disorder includes the physical as well as the intellectual disability. And these disabilities can be from mild to moderate in nature. And here the role of nurse cannot be neglected and actually plays a very crucial role in order to provide the tailored patient-centered comprehensive approach throughout their lives. So in this regard, I can say that with the rise in life expectancy of individuals with Down syndrome, the role of nurses are crucial and emphasizing the need for providing comprehensive care throughout their lives. Nursing care emphasizes a patient-centered approach, so it's essential for the nurses to tailor their practice, and a structured care in the development of these children is actually the need of an hour, because in the nursing profession, this is highly a gray area where we have the difficulty in order to get the evidence-based data, especially related to the Down syndrome and the need based on that. Beyond the physical features, Down syndrome is associated with the various health challenges and that can affect the overall quality of life. In this regard, there is a study which was published in 2015 and shows the complete insight of the disease, in which it was clearly stated that the Down syndrome involves the multiple system disorders, which affects such as nervous system, cardiovascular system, GI system, skin system, etc. And thus, the nursing care considerations also includes all the interventions which are involved these type of systems of human body. First one is the growth and development monitoring. In this regard, nurses should get the baseline data of height, weight, head circumference, chest circumference at the time of birth and during all the visits of immunization schedule. Second, in terms of cardiac problems, the role of nurse is the monitoring of vital signs and educate the parents to get the data related to the cardiac distress such as heart murmur, cyanosis, poor feeding, and preparing the family even for the surgical intervention if needed. Here, the role of nurse is perioperative. That means the nurse can assist in the preoperative phase, intraoperative phase, as well as the postoperative phase of these patients. Next one is the feeding and nutrition. Here, the hypotonia and the protruding tongue can make the feeding difficult. And in this regard, we should encourage the females and the mothers for the exclusively breastfeeding. Secondly, teach them to provide the feeding in an appropriate position and proper feeding techniques. Next one is for the respiratory care. Infants often have the narrow nasal passages and low muscle tone, which increase the risk for respiratory infections and the sleep apnea. So for this, we need to encourage the parents for the proper immunization. For the hearing and vision, assist in eye, ear examination, regular dewaxing if there is an incidence of wax accumulation, and the sleep studies are also recommended in the literature for the OSA. And we can also refer the patients for the consultations. Next one, for the infection control, emphasize on the proper hand hygiene and the immunization. For the gastrointestinal issue, recommend a high fiber diet and the adequate hydration because the patients may have the problem of constipation, diarrhea, etc. For the dental care, encourage regular dental checkups and teach parents how to effectively help their children with the oral care. So in this regard, this is a study which was published in Asian Journal of Oral Health and Allied Sciences in 2025, which indicates the Indian parents' perspectives on the impact and the challenges faced, in which these were the findings such as the health issues related to oral care, then the poor oral health quality on quality of life. And in this regard, one parent desire for the comprehensive dental plan indicates that, yes, I think it is much needed as the dental care is most neglected in these patients. So the major key facts in terms of oral care for the Down syndrome patients or the individuals, the first one is the poor oral hygiene, which is due to hypotonia and the impaired motor skills. And second one is the sensory issues, which cause them to dislike the feeling of toothbrush or the toothpaste. So in the multidisciplinary approach, the effort of role of nurse cannot be neglected, and they play a vital role in the specialized care referencing the unique oral health challenges. And the oral care, including in the nursing care strategies, focused on first one is prevention, second one is adaptation, and third one is the consistent routine. So in terms of prevention, we need to educate or promote the patients for the oral hygiene education. Second one is or use of oral hygiene aids. Third one is fluoride containing toothpaste. Next one is the dietary consideration, in which we need to educate the parents that limit the sugar, snacks content, and high fiber rich diet, basically the balanced diet. And next one is the regular frequent dental visits with the proper follow-up. Next one, in terms of adaptation, it includes three aspects. First one is the positive reinforcement. That means we need to use the reassurance approach in order to teach how to do the oral care. Second one is we need to have the slower pace so that we can give the extra time for the demonstration as well as the re-demonstration. And next one is tell, show, do technique. That means firstly, you need to demonstrate how to give the oral care, and later on, you should be able to get the re-demonstration from the parents or the individual if they are able to do so. Next one is the consistent routine. It includes brush the teeth twice daily. Keep the routine consistent by brushing at the same time and at the same place. Second one is music. In order to remove the distraction, we can use the toys, music, and then let the individual participate in the brushing their own teeth before a caregiver provides a more thorough cleaning. And next one, yes, frequent dental visits with the follow-up. Best practices for the oral hygiene includes the tailored strategies, in which we have the three-sided toothbrush. That means we need to recommend this type of toothbrushes, modified toothbrush, then ergonomic handles, and next one is the fluoride containing toothpaste. Why fluoride containing toothpaste? Actually, research says that it strengthens the enamel, and secondly, reduce the microbial growth in the oral cavity. These are the examples of these aids. And the pointers for brushing: brush at least twice a day, brush lightly, brush for at least 2 minutes, fix a standard routine, always use a toothbrush with the soft bristles, and change your toothbrush regularly. Electric brush is fine, but it's not always recommended or necessary. And there is a manual which is published by the Ministry of Health and Family Welfare for the proper training of oral hygiene, which includes 3 steps. First one is brushing teeth, then cleaning the tongue, and last one is rinsing of mouth. And it was stated that the mouth should be rinsed with water after meal. If possible, switch your water in mouth for 2 minutes or at least 60 seconds. These are the instructions. We need to educate the parents how to do the oral care. And always we need to educate that never use the frayed toothbrushes. Next one, in terms of language communication and social development, parents can be the best therapists for this. And everyday activities for the language teaching. For the bathing, we can educate parents that you could play with the doll at bath times, and as you wash the child face, he or she could the same to do with the doll. For the dressing, place his or her clothes out in the morning and ask his or him to find her socks, shirt, trouser, etc. And once he or she has selected an item correctly, tell him or her to put his trousers or clothes by its own. For the meal times on table, talk about the knives, utensils, and then recollect the data from the patient. And for the bedtime, the storytelling is the best option for better adaptation. And for the play therapy, encourage the child to handle a wide variety of objects so that it can practice grasping and adapting its hands to the different shapes. Teach the child how to transfer objects from one hand to another. And all children should be encouraged to play outdoors. So in the conclusion, I can say that making a difference in the health of a person with the Down syndrome may go slowly at first, but determination can bring the positive results and significant impact on the quality of life. And a take-home message from my side is focus on ability rather than the disabilities. Thank you so much.
Thank you, ma'am, for sharing your expertise with us today. And moving on to the next presentation, psychological consideration by Dr. Pawan Gupta sir. And our chairperson, Dr. Rajiv Kumar sir, will invite our guest speaker.
So it is my privilege to introduce the next speaker of this session, Dr. Pawan Kumar Gupta, who is professor in the Department of Psychiatry, Kgmu, Lucknow. His qualification is MBBS and MD in psychiatry, and he has received travel fellowship from World Psychiatric Association, international training seminar in child and adolescent psychiatry, Venice, Italy, and also he has done the training and educational fellowship from Asian Federation of Early Career Psychiatrists from Kochi. He has several life member. He is the member of several societies and have the is the life fellow member, which includes the Indian Association of Child and Adolescent Mental Health, International Association for Child and Adolescent Psychiatry and Allied Professors, Indian Psychiatric Society and its Central Zone, Indian Association of Social Psychiatry, Addiction Psychiatry Society of India, and Indian Association of Clinical Psychiatry. And he is also the editorial and committee roles in, he is associate editor in Indian Journal of Behavioral Sciences and member of Social Media Committee of IACP. His area of interest include the child and adolescent psychiatry and behavior addiction. So on behalf of this conference, I welcome you, sir, and we are eager to listen from you.
Thank you, Professor Rajiv. And thank you, Dr. Rhythm, to inviting me in this presentation. Definitely many of aspects of Down syndrome has been talked about, a lot of comorbidities and various physical comorbidities in the Down syndrome person. There are many psychiatric comorbidities. My presentation is not going to cover psychiatric comorbidities because it requires similar management as per the diagnostic protocols. Whatever the diagnosis is, we do that. I'm focusing my presentation more of a behavioral issues and psychological issues, which generally they come in the clinics for the management. Because covering a psychiatric comorbidity will take a lot of time and it is beyond the scope of this presentation. So it is commonly associated with intellectual disability, which is well known. And every child of a Down syndrome is unique with a wide range of abilities also. I will talk about this. They have a lot of strengths, which as compared to typically developing children. And they have a certain personality traits. And they have a unique developmental milestones also. So common psychological problems are intellectual disability, which is most common. They have a mild to moderate level of intellectual disability. They have a communication and language difficulties. They have emotional regulation challenges because of overall poor development of the brain, especially the areas which need to be matured for the proper emotional regulation, and psychiatric comorbidities. Common behavioral problems which is observed and being presented in the clinics are impulsivity, aggression, temper tantrums. They have anxiety and repetitive behaviors. Most of the behavioral issues may be related to anxiety or because of impulsivity. Another common comorbidities are ADHD, and social withdrawal is also seen in certain cases. So what kind of behavioral strategies? These are the common issues which we label them as behavioral issues apart from the psychiatric comorbidities like mood disorder, depression, anxiety disorders. But these are the which are non-diagnostic behavioral issues. So as in previous presentation, it has been said that they require a certain routine to manage common behavioral problems. But what need to be done? Generally, we see that parents become critical about, and sometimes they try to control the behavior by firmness, by hard routine. But it is more required that positive reinforced techniques should be used. That behaviors which are good must be appreciated, and behaviors which are less harmful must be ignored. Clear communication strategies should be used, like complex tasks should be divided into multiple steps. Best possible to chalk it down into a simple sentences and one step at one time. Offering choices. Obviously, even we as a normal cognitive individual, when we are provided with lot of choices, we often get confused. So children or person with Down syndrome, it is a general rule that if you want to get them done something, provide less number of choices with a clear instruction. Parental training and family involvement is paramount in these cases. Support is highly necessary, and school-based interventions and special education support is needed in most of the cases. Another issues which we face, hypersexuality in Down syndrome. They develop and sometime emergent during the early adolescence. Why? Because they have a less developmental cerebral cortex, or you can say the higher areas get less mature, so they are less able to control their inhibitions and impulsivity. So the common behavior observed: inappropriate touching of self or others, public masturbation, and socially intrusive affection. Common causes are because of impulsivity, poor social understanding, poor social judgment. What is the management of these issues? That first and foremost thing that we should educate the parents as well as the uh, person using simple rules. As I said, that these are common problems. They are the normal development of the children. The only issue is that they are not able to handle it properly. So we need to develop strategies to manage impulsivity and sexual behaviors. Most of the time, because of hypersexual behavior, there are a lot of stigma. In that case also, family should be educated. Social skill training, because this require area of safety, this require area of personal care, this require a training into the expression of sexual behaviors properly. Also, in severe cases, pharmacological treatment are also used. Like in some cases, most of the cases, we use low doses antipsychotics, but in some cases, like you might have heard that cyproheptadine is being also used to reduce the hypersexual behaviors. Another problematic issues which is seen in Down syndrome cases are self-harming behaviors like head banging, skin picking, cutting, biting. All these are very commonly presented. Reasons could be multiple. Reasons could be because of they are not able to express themselves, which in turns create frustration or anxiety among them. And when they do not know how to express this, they try to cut themselves. Another reason is they do it because of pain or discomfort, and they learn it as a expressive mechanism, and they try to, along with that, they are they have a sensory deficits also. Sensory deficits is commonly known in autistic disorders and various others disorder. So in this area also they have a sensory deficits, so they try to self stimulate to gain that sense of sensory stimulation. They try to cut or bite themselves, and it is also a way of getting attention of people around them. So these are the various issues. The management strategy lies in identifying the why. So conducting a functional behavioral assessment. What is functional behavioral assessment? Identifying the antecedent of the behavior, identify the behavior itself, and what is the consequence. It is a ABC model. So generally we take any, and this should be created, this ABC model should be created for each and every behavior and should be handled. And then the strategy, like either you can change the antecedent, either you cannot change the behavior, but either you can change the antecedent or you can change the outcome. And in both of these intervention, behavior gradually shift from non harming behaviors. So alternative communication skills like use of antecedents can be changed. Like suppose a children having a difficulty in academic issue. Whenever the child, I have a case when it also, but I will not go into the detail. But suppose a child is going to show temper tantrums, he started hurting, head banging in the class when the some essay is being asked or something is being asked to write, and child started headbanging. Generally what happens, teacher runs and stop them and try to take the work from them, or they exempt the work for them. Ideal strategy should be that if you identify, you can give them certain cards like visual cards, so that when they feel difficulty they can show the help card, or they can show the assist card, something like that. And in spite of taking the task away or providing exemption, you can stay there, you can simplify, help them to manage the task. So these ABC model should be used in each and every behaviors. Providing sensory alternative, like sometime you can give chew toys, balls, weighted blankets, which provide them sensory stimulation, uh, and they can be soothed. Role of psychotherapy and support are not exactly CBT, but CBT can be adapted for emotional regulation. The principle of CBT, cognitive behavioral stimulation, can be used for their emotional regulation. I hope because CBT is a whole systematic, proper management skills. I cannot go into the details, but usually here we do a behavioral assessment, we do a cognitive assessment, and we provide certain behavioral experiment which can change, which can provide an opportunity to discuss about the cognitive impact on the person, and person can change, use the experiment and learn new behaviors. Social skill training, family therapy, and multidisciplinary approach is the norm of these cases. Use of antipsychotic is there for controlling impulsivity, aggression, self-injurious behavior, but in severe cases where behavioral approach not being handled or person is not being accessible for the uh, any non-pharmacological treatment. So commonly we use risperidone, aripiprazole in very low doses, like 0.5 milligram risperidone, either BD or TDS doses. Aripiprazole, we start from very low dose, like 2 milligram, to gradually go up to maximum. We can go up to 10 milligram in these cases, because usually intellectual disabilities, comorbidity, brain capacity is compromised, so risk of side effects is also very high. So generally we follow the rule that is start low, go slow technique. Monitoring for side effects like weight gain, metabolic syndrome, and sedation. And usually it is being used as a secondary or adjunctive to the behavioral approach. This is a thing like we should look for positive aspects and strength in all the disabilities, I remember when I was doing my MD, there was no talk related to positive aspects and strength of disorders. Now we have a in every presentation, and we see when we have an intention to present what is the positive aspect of certain disorders or certain disabilities, we usually find a, you can say that level 1 evidence. Even you can have a meta-analysis, you can have a systematic reviews available based on the strength of certain disorders. Each disorders and disability comes with problems, but at the same time it comes with lot of पॉजिटिव एस्पेक्ट्स आई हैव अ विटनेस्ड पहले हमारे यहाँ यूनिवर्सिटी में पहले हम लोग के ओपीडी में सर्टिफिकेशन की एक सेपरेट ओपीडी चलती थी. So usually we are residents and at that time. So I have observed that there was an incident I just wanted to share, that I was having certain incident in my family. It was a death of a very close person, and I was, because OPD was rushed and I was not able to handle myself. I was trying to leave, and there was no expression, nobody around me, nobody. There was a child sitting in the waiting area, and I I was just talking on the phone and trying to leave the handing over. That child said, "Mama, uncle ko kya ho gaya? Why uncle is crying?" So that was because I was not crying, but I was almost about to cry. It was like I burst out, and immediately, as the child said that why he's crying, immediately tears came out. I realized that there is certain things that these children do feel and understand, which commonly we are not able to understand. They have a heightened sense of empathy. They have a heightened sense of social warmth. Yesterday was my OPD. I again witnessed a 3-year-old Down syndrome child. Although the intellectual functioning was borderline, but the emotional reactions and social reactions are extremely good, as the rest of the areas was compromised. So these are the certain strength, and this is not just a feeling. This has been well proven in the reviews. They have a strong social warmth and empathy. They have a high level of affection and friendliness. And because of so many intervention, it is the impact of so many intervention being done. The people who are following all the medical advices and rehabilitative services, generally they become more aware, but along with the help of personal capacity of the person with Down syndrome, generally it has been observed that family resilience is overall very good. They have unique talents and abilities beyond limitations, and they have a high capacity of empathy and emotional sensitivity. So with this, I would like to conclude my presentation that children with Down syndrome requires holistic, individualized psychological cares, like for behavioral management, ABA analysis, all these things. There should be a balance between the behavioral strategies, pharmacotherapy, and family support. There are a lot of concern regarding the side effects. So we need to balance we need to psychoeducate the family members that sometime it is very much needed and it is required to make them learn certain behavioral techniques and facilitate the rest of the therapy. And it is very much helpful to counsel the parents, because parents ask, डॉक्टर साहब अब इसका कुछ नहीं हो सकता, डॉक्टर साहब ये आगे जीवन में कुछ नहीं करेगा. So what then these research help me to counsel that there are certain strength, positive aspects which can make better life, which can contribute to your family and overall life. So बुद्धि सब कुछ नहीं है, function सब कुछ नहीं है, looks सब कुछ नहीं है. There are certain things where these children are highly capacitated, they have a high capacity as compared to us, and it can be a contribution to your family. So these are the certain things which we do. So this is all. Thank you so much.
Thank you, sir, for such an engaging session. Now, coming to the end of this session, I would like to call our chairpersons, Dr. Rajiv sir, as well as Dr. Amit sir, for felicitating our guest speakers. I kindly request Dr. Vivek Bain sir to the dais. And I request Dr. A.K. Gupta sir. I'd like to invite Miss Anjali Arora ma'am. I would invite Pawan Gupta sir. Now I'd like to welcome and invite Dr. Anju Agarwal ma'am, HOD, Professor of Department of Gynecology, for felicitating our chairpersons and the chairman of the B.E.S.T. Thank you all for your active participation. Thank you. PC ma'am is on the way and the inaugural ceremony has to be done. I kindly request everyone to be seated.
इधर ही बोल रही हूँ। बहुत अच्छे, बहुत ही अच्छे। वहां तक तार जाएगा, हवा में आ जाएगा। 5 मीटर वाला लाए अपना। अब क्या भारी पड़ेगा, इतने बड़े ट्राइपॉड पे तुमने लगा दिया।
क्या दूर है वो
नहीं जा पाएगा वहां तक के, उसने बहुत दूर लगा दिया। इतनी हवा में तार नहीं सही लगेगा यार। बस यहीं पर, तब भी हवा ही में रहने वाला था। हाँ एकदम। भाई सिर्फ एक बार चेक करने को बोला है, वहां रखना नहीं है परमानेंट। चेक करके अभी यहाँ रख दो, फिर वापस वहां रख देना शुरू होने में। अरे बाप रे बाप। ऑन करो। ऑन नहीं क्या, आया नहीं है। कनेक्ट नहीं है विनायक।
यहाँ पे हो।
हाँ बुक।
Good afternoon, everyone. A very warm welcome to the first National Interprofessional Healthcare Symposium on the theme Collaborative Care, a multidisciplinary approach to the special needs dental patients, which is jointly organized by Kgmu B.E.S.T in collaboration with the Down Syndrome Federation of India. It is indeed an honor to have among us today eminent dignitaries who have kindly joined us to grace this inaugural session. To begin this ceremony, I request our students to kindly extend a floral welcome to the dignitaries seated on the dais. Honorable Vice Chancellor KGMU Dr. Sonia Nityanand Ma'am, Padam Shri Awardee, I welcome you, ma'am. Dr. G.K. Singh, Dean, Faculty of Dental Sciences. Dr. Anju Agarwal, Organizing Chairperson. Dr. Pramila Verma, Scientific Coordinator. Dr. Rhythm, Organizing Secretary. Now, off the dais, I offer my welcome to senior teachers and head of the departments. Dr. Pradeep Tandon, sir. Dr. Anil Kumar Gupta, sir. Dr. Rajiv Kumar Singh, sir. Dr. Vivek, sir. Dr. Suleiman, sir. I formally welcome you all to this scientific session. Now, moving on to the next session, to mark this auspicious beginning, I now request all the dignitaries on the dais to kindly proceed for the lighting of the lamp, symbolizing the dispelling of darkness and the ushering in of knowledge. Ma'am and sir, please. Dr. Didi ma'am, kindly come forward for the lighting of the lamp. Yeah. Thank you, respected dignitaries. Now, moving on to the next session, I now request our organizing chairperson, Dr. Anju Agarwal, ma'am, to kindly deliver the welcome address for the session. Ma'am, please.
A very good morning, Honorable VC Ma'am, Dean Dental, all our honorable faculty who have joined us from far and wide, and dear delegates, Dr. Pramila and Dr. Rhythm. A very warm welcome to you all to this first National Interprofessional Healthcare Symposium, which is unique in that KGMU is collaborating with the Down Syndrome Federation of India. And as you know, Down syndrome babies and children, they have special needs. And as part of those special needs, they also have a need for dental treatment. So how to go about it, that is what you'll be learning in today's workshop, which we know will be very knowledge increasing for you, very interesting, because we have eminent faculty. I particularly thank our Down Syndrome Federation of India representatives who have joined us from far, Dr. Pradeep Kumar, Dr. Nidhi Gupta, and of course, all our local faculty who have taken such interesting lectures. In fact, I was listening to the last lecture when I joined in. It was very heart-touching, and I'm sure all of you are gaining from it. So a very warm welcome to you all, and we look forward to many more such collaborative symposia and value-added courses for our students and our faculty. I congratulate Dr. Ritin on conceptualizing and organizing the whole workshop. A very warm welcome to you all.
Thank you, ma'am, for your kind words. Now, I request Dr. G.K. Singh, Dean, Faculty of Dental Sciences, to kindly address the gathering.
Good afternoon, all of you, dear delegates, and I heartily welcome our Chief Guest and Padam Shri Vice Chancellor, Professor Sonia Nityanand Ma'am, Organizing Chairman, dignitaries on dais, Dr. Anju Lumba, both co-organizing chairman, Dr. Rigam, as secretary, organizing secretary, and other heads of departments and all the faculty members and my teachers in the off dais, Dr. Pradeep Tandon sir. I welcome all of you. As you know, the Down syndrome is a genetic oriented disease, or it is a anomalies, you can say. It is because of the chromosomes 21, and it is also known as the trisomy 21 because it is a overlapping of the chromosomes, and its features are unique in sense because you can see the patient and you can diagnose the patient as well because their eyes are bulging, nasal bridge is depressed, facial asymmetry or lack of coordinations of the muscles and musculature or neuromuscular coordinations, in poor oral hygiene, and the irregular teeth are there. My specialty is also involved, orthodontics is also involved because the most of patients have the irregular teeth, and we are treating these patients for the more than 2 or 3 years sometimes because they have lack of coordination also with the sense as well as with the musculature or habits. That's why the treatment is more longer than the usual patients of the dental orthodontic dental patients. I thanks to the organizing teams for inviting me as a guest, and I hope you will take message from the year to take care of the individuals with the multi-specialty interdisciplinary approach so that they can get each and everything at a single platform. That is a unique starting of this from this institute as the first symposium of Down syndromes, or you can say with the other syndromes also. Not only the Down syndromes, we can go for the other syndromes also. And thank you all.
Thank you, sir. We will now listen to a special video message by Dr. Sureka Ramachandran, President, Down Syndrome Federation of India. At the end of this
Namaskar. I am Dr. Surekha Ramachandran, the President of the Down Syndrome Federation of India. And for the past 40 years, Down Syndrome Federation has dedicated their entire purpose to the cause of persons with Down syndrome. Our journey has been about creating a strong, very strong community for parents where they find solace, guidance, support, and a lot of strength. Alongside, we have built a panel of committed doctors who walk with us to ensure that our children get the best care they deserve. We continue to work for the cause. One aspect of health that I found has constantly been ignored or not understood is oral health. Oral health is not just the mouth, and it affects nutrition, diet, speech, food, swallowing, confidence, and the overall well being of our children. Every other intervention, dental care, oral care is a must. This particular symposium, or the first national interprofessional healthcare symposium that you are organizing by the King George's Medical University in association with the DSFI, gives us an amazing sense of pride. This symposium is a landmark step in bringing experts from different fields together and with a shared vision of holistic care of persons with Down syndrome and other special needs. I extend my heartfelt congratulations to the organizers and my warmest wishes for the success of the important initiative. May this collaboration set the foundation for more inclusive, integrated healthcare for our community. Thank you so much, and honestly, I wish you all the best. God bless you.
Hello everyone, I am Ashi Gupta. I have Down syndrome. I am very excited. Do you know why something big is going on to happen on 13 September? Stay tuned.
What an inspiring video it was. Now, moving on to the next session, we are truly privileged to have with us today our chief guest, Honorable Vice Chancellor KGMU, Dr. Sonia Nityanand, ma'am, Padam Shri Awardee. I request you, ma'am, to kindly deliver the inaugural address.
Thank you. Dr. Anju Agarwal, who's the organizing chairman, Dr. G.K. Singh, Dean of Faculty of Dental Sciences, Dr. Pramila Verma, the scientific coordinator, and Dr. Rhythm, the organizing secretary. Dr. Pradeep Gupta, Dr. Pradeep Kumar, I know, has left, but Dr. Nidhi Gupta, you're there from the Downs Foundation of India, Downs Federation, I think, Down Syndrome Federation of India. And we just heard Dr. Surekha Ramachandran, I don't know if she's there, and all the esteemed faculty members from KGMU and who've come from outside KGMU to impart their expertise, and all the participants. A very good morning to all of you, and it's indeed a great honor that the KGMU B.E.S.T, which is building essential skills through training. It's been a program which has been launched by KGMU in the recent past, a kind of a skill-based education platform, is organizing this first national interprofessional healthcare symposium. All interprofessional healthcare symposiums are very, very important, because now there is a high level of specialization, and it's very important for specializations to come under a roof. So being organized in a very important area, which is Down syndrome, collaborative care, a multidisciplinary approach to the special needs, especially of dental patients. So I'm very happy that this symposium has been organized, because Down syndrome stands for special children. And once born, it is our responsibility to extend all healthcare needs to them. This is a global goal of health equity to all marginalized populations, all financially deprived populations. So I'm so happy, because on 26th of January, on the Republic Day, we had decided in Kgmu that we are going to work towards health equity. And this is one of the steps where we are trying to take care of marginalized population. And what better thing to organize than by a dental team? Because as already highlighted by the president, the dental hygiene, the dental, taking care of the dental part has many implications in patients, and it is a difficult area for children with special needs. So how to identify what problems are there, how to identify them, how to tackle them will be covered in this symposium. I would like to thank the Down Syndrome Federation of India in collaborating with Kgmu for this symposium today. And I do hope that the collaboration is in more areas, and it's a greater collaboration for the benefit of these children. So thank you for inviting me to be the chief guest. And I again would like to congratulate the B.E.S.T team for choosing this area, and the dental team, Dr. Rhythm, and your the whole team that you chose this area to be addressed. So thank you.
Thank you, ma'am, for your inspiring words. I would now request you, ma'am, to kindly stay back for a moment as I invite Dr. G.K. Singh, Dean, Faculty of Dental Sciences, to felicitate our Honorable Vice Chancellor, Dr. Sonia Nityanan, ma'am. At this point, I would also like to draw the attention of everyone present here to the beautiful painting displayed here, which has been created by Miss Arshi Gupta, daughter of Dr. Nidhi Gupta, as a reflection of her talent and spirit. I now request our Honorable Vice Chancellor, ma'am, to kindly stay with us for a few moments as we proceed with further felicitation. I request our Honorable Vice Chancellor, ma'am, to kindly felicitate our distinguished speaker, Dr. Nidhi Gupta, ma'am. I would also like to draw the attention of everyone to the painting displayed here, which is created by Dr. Aniket Chandra Saxena, BB's final year student. Next, moving on, I request Dr. Pramila Verma ma'am to kindly felicitate Dr. G.K. Singh, Dean Faculty of Dental Sciences. The painting here is drawn by Ms. Ashi Gupta. Next, moving on, I request Dr. Rida ma'am to kindly come forward and felicitate Dr. Anju Agarwal ma'am. I again request Dr. Rida ma'am to felicitate Dr. Pramila Verma ma'am. I request all the dignitaries to kindly take the seat now. Now, to formally conclude the inaugural session, I request our organizing secretary, Dr. Rida ma'am, to kindly deliver the vote of thanks.
It is said that it is in the giving of knowledge that we truly receive. Today, as we conclude the inaugural session of the first National Interprofessional Healthcare Symposium organized by the King George's Medical University under the banner of Kgmu B.E.S.T and in collaboration with the Down Syndrome Federation of India, it is with a great pride and a heartfelt gratitude that I stand before you to deliver the vote of thanks. First and foremost, we are deeply thankful to our respected Honorable Vice Chancellor, Professor Sonia Nityanand, who has a visionary leadership and her constant support has made this symposium possible. Ma'am, your guidance continues to inspire us towards excellence in health, care, education, and service. Our sincere appreciation goes to our esteemed Dean, Faculty of Dental Sciences, Professor Gulshan Kumar Singh, whose encouragement in the direction were important for executing of the event dedicated to the advancement of the collaborative care of special needs patients. I also give my special thanks to Dr. Sanjeev Srivastav, who unfortunately could not join us today. He's the president of the UP State Dental Council, and he was generous to provide the symposium with 6 CD points. And a great thanks to the esteemed guest speakers and keynote speakers for the day. Our keynote speakers, Dr. M. Pradeep Kumar, who had to leave early because he had a flight, and Dr. Nidhi Gupta, my BDS batchmate, my friend, a very special friend. Thank you so much for being here with us and sharing your knowledge with us. Our thanks to our learned guest speakers, Dr. Anil Kumar Gupta, Dr. Vivek Bains, Dr. Pavan Gupta, and Ms. Anjali, for giving insights from all the aspects, the multidisciplinary aspects you touched upon, which as a clinician, everybody should know while dealing with special needs patients. Thank you so much. I like to acknowledge the efforts of the chairpersons of the sessions, whose meaningful remarks they added to the extended knowledge, and the judges of the poster competition who have judged the posters assigned to them so beautifully and so nicely, and they gave a constructive feedback to to guide the young professionals towards the continued innovation and excellence. Helen Keller once said, "Alone we can do so little, and together we can do so much." The organizing team behind the whole program, the backstage is the place where everything happens before it can be seen on stage. I take this opportunity and express my gratitude for the amazing and meticulous organizing team working behind the scenes to make the event happen. Dr. Anju Agarwal, the organizing chairperson, the ever smiling, ever helpful, and ever encouraging. To you, ma'am, we are ever grateful. Dr. Pramila Verma, the scientific coordinator of the event, our guiding light and pillar of our strength. Dr. Richa Khanna, the co-organizing secretary, a thoughtful and a quick response member of our team. Dr. Rameshwari Singhal, the program coordinator, who makes work fun by adding moments of laughter and smiles. Dr. Nishi Singh, she is also not here with us today. She had to leave for some exam. The dedicated and the sincere member of our team. My postgraduate residents, running in all directions, understanding my words even before I complete my sentence, and bearing and balancing all with the patient load they have. Thank you, dear students. May you all be successful in all the spheres of my life, of your life. We are grateful to the principals, the heads of the departments of various faculties, the faculty members, senior faculty members, and all the participants, both online and offline, who actively engaged with the sessions and made the symposium truly interdisciplinary learning platform. Ma'am, here I would like to tell that the symposium, we had a very good response, and we had a total of 280 registrations, out of which 170 were online and 110 were in the on-site mode. Apart from that, we also had a poster competition in which 80 participants, both from the undergraduate and postgraduate categories, they have participated, and we were thrilled to see amount of effort the students have put into expressing their views and opinions on the various themes, like how to design a clinic for special care patients, interdisciplinary approach, etc. Thank you, students. A special thanks to the technical team from the IIT cell, Mr. Farhan, Mr. Vinayak, whose seamless coordination enabled us. Thank you so much, ma'am. We are so happy that you're here. Thank you, ma'am. Special thanks to the faculty in charge of Kalam Center for the infrastructural support. We deeply appreciate the relentless effort of our support staff. And a very special thanks to my better half, Dr. Vivek B.E.S.T, for all his positive inputs, critical appraisals, and all the care. This symposium reminds us that collaborative care is not a professional duty, but also a compassionate responsibility towards individuals with special needs. So, I would conclude by saying that together we can and together we will. Thank you so much.
Thank you, ma'am, for your kind words. I request everyone present here to kindly rise for the national anthem. With this, we formally conclude the inaugural session of the symposium. We now move forward to the next section of this academic gathering. For the third session, I request Dr. Richa ma'am to kindly come forward and take over the proceedings.
Thank you, Dr. Muskan. So the next session is very special, a keynote talk, and it's really very close to all the dental surgeons. It is titled as More Than Meets the Eye, Dental Dooms in Special Needs, Obvious and Hidden. And a very special speaker here is Dr. Nidhi Gupta. To introduce the speaker and welcome her, I will now invite our chairpersons for the session, Dr. Pooja Mahar and Dr. Gaurav Jain. And I will request Dr. Pooja to kindly introduce our speaker.
Good afternoon, everyone. I myself, Dr. Pooja Mahar, Professor of Clinical and Child Psychology in the Department of Psychiatry, Kgmu. It is my proud privilege to introduce our keynote speaker, Dr. Nidhi Gupta. He is a co-founder and director, please ma'am come, of Abhyasi Smile Special Foundation since 2018 and having 20 years of experience in and dealing with the dental care of special children's and lot many other disorders. She has done her post-graduation in endodontics from Mumbai University, Mumbai, and graduated from Baba Fed University, Patiala, Punjab. She's affiliated with associations, important associations like Autism for Action for Autism, Down Syndrome Federation of India, FSMA, Society for Spine and Muscle Atrophy, and involved with premier special needs organizations like India Autism Center. She is being awarded and got recognition by many associations. One of them is awarded with Best Doctor Award by DSFI in 2021, facilitated by Maheshwari Club of Delhi for their selfless services in 2023. She has been university and college topper for various subjects. She has been author and co-author for many publications, especially with regards to dental issues in person with Down syndrome. She has published a lot of papers in international and national journals. She has contributed to textbook on Down syndrome by Indian Academy of Pediatrics. In activities, she has done a lot of, there is a list of activities she has done. Some of them are workshops, panel discussions, awareness programs, symposiums, conferences, and participated as expert in Asian Pacific Down Syndrome Federation with 800 attendees in 2020, and has been a keynote speaker for the conferences. I invite you, ma'am, for the keynote speaker address for this symposium. And thank you so much for inviting me for the chair this session. Please, ma'am.
Good afternoon, everyone.
It is with this by PPT.
कौन सी है मैम की कौन सी है कहाँ पे है
डॉक्टर एकदम के कंप्यूटर
अच्छा अच्छा प्रणव विगन में हमारा सिस्टम लगा कहाँ है मैम का सिस्टम है क्या मेल पे मेल है तो
Okay, so before the formal presentation starts, I want to know how many children or adults with Down syndrome have you ever seen in your life? Have you ever seen them? I'm not talking about have you treated them. Have you seen them? Yeah, one hand, two hands. Now many hands are raising. Seen, we have seen them, right? But like Dr. Pawan said, Anjali ma'am said, Dr. Ben said, it's difficult to treat them in OPD setting. Will you all agree with me? Yes or yes? Yes, it's difficult. We dentists have a very novel profession. We are treating, we are giving them care when all the senses have kicked in. They can see, they can smell, they may be aversive to touch. We are not just giving them a pill and treating and sending them back. We are actually going in the mouth, right? And this mouth is the most sensitive part of a body. Yeah. So as dentist, what we can do as budding dentists, you are the young blood of India and our society, and we have so many hopes pinned in for you. What can we do? Is our role limited only to the oral care or uplifting the quality of their life as a whole human being? This is the question I have for all of you. And we have covered, there were 5 presentations, and believe me, they all gave me goosebumps. But I also had the confidence that so much of knowledge and sensitivity is already there in the community. But how to implement it and the amount of work we have done, the pictures you will see in my presentation are all live. They are real pictures, real cases we have done, and I all request you that because the information is sensitive, please don't take the photograph of at least the patients or the children and adult we have treated so far. Right? Dr. Baines is saying continue for 2 more minutes. So the moment I landed in Lucknow, there was this big slogan written, "Muskuraiye aap Lucknow mein hai." And I found an instant reason to smile being part of this first National Interprofessional Symposium. And my heartfelt thanks to everyone present here, to Dean Faculty, Dr. Gulshan, to Dr. Sonia, to Dr. Rhythm, Dr. Pramila, and a lovely audience who is still sticking here, though it's a lunchtime, sticking with us. So maybe I don't have the presentation, but I have ratified the presentation by heart, so I can go on like this, even if it doesn't work. When we say that Down syndrome children or autism, children with autism, वो disabled हैं, वो विकलांग हैं, what is the mindset we are working from? We take them as children of lesser God. We think they cannot do anything in their lives. We have that mindset. हमें लगता है यार ये तो बुद्धू है, ये कुछ नहीं कर सकेगा. But you know, there are so many studies going in the stream of philosophy where they are saying they are not buddhu, they are living buddhas. They don't have this, but they have this. They connect with you from here. As Dr. I think Pawan, he mentioned, they have heightened sense of friendliness, compassion, and you know what all we look for? We all look for all these virtues of humanity as we live our life, right? They already have. They already have. So when we interact with children and adults, where we say they have intellectual disabilities or we say they are disabled, I say they are neurodivergent. I use the term neurodivergent. Neurodivergence is what? It is actually God's play where he doesn't want, you know, the monotony. They wanted diversity. We talk about ethnic diversity, diversity in culture, language, religion. But here we are talking about neurodiversity, how the brain get wired and how some percentage of our worldly population react to a stimulus differently. Right? Often when you will start with your clinical practice, you will see many children and adults with Down syndrome or neurodivergence in your clinic. There is something which will stop you to treat them. Maybe their concomitant medical history. As Dr. Pradeep said, they may be carrying a lot many medical issues within their body, right? Are we really prepared as a dentist to understand what are the medical issues and how we can work upon that? Along with that kicks in sensory sensitivity. They are sensitive to a lot of stimulus because a dental clinic is like a live setting where you see the drills, you hear the sound of the drills, you can see patient coming and going, you can sense some smell of some chemicals used. So everything and their senses are super active, right? So in this presentation, we are what should be done has been, you know, covered in the last 5 presentations. How should we do it and what have we done still so far is what I am going to cover in a broader way. And I want this discussion to be really, really interactive because in times to come, we have to open our arms and heart to embrace neurodiversity. It is going to be a new normal for us to start treating and taking special care, you know, in our gamut of work. So is the presentation ready? Okay. Okay. I'm okay. This one? Yes. This one, no? So more than meets the eye, we all know that there's a set of dental problems. But in this presentation, we are going to dive deeper to know what we can see beyond what we don't see. How to go?
Yes.
I've already talked about what is neurodivergence. So neurodivergence is not a medical term. It's an umbrella term where lots of like autism, trisomy 21, we call it Down syndrome. Down syndrome doesn't mean they have anything down with them. It was the name of the scientist who discovered Down syndrome. Dyslexia, ADHD. So it's like an umbrella term which defines that there is a certain percentage of individuals in our community whom if you give a regular stimulus, the response may be difficult or different. So in my presentation, I'm going to cover 2 neurodivergent models. One is Down syndrome, as has already been covered in the previous presentation, and another is autism. The incidence of autism is almost 1 into 68 or 1 into 100. And Down syndrome is 1 into 600 to 800, depending upon from where the data has been collected. Why do you want to understand neurodivergent individuals? My question to you. Anyone can answer. Why do you need? We already are overloaded with normal neurotypical population. Why do we need to understand them? As I already told, we have to brace this percentage of population with the neurodiagnostic techniques in place. The percentage of neurodivergent people diagnosed with autism or with Down syndrome or other traits is increasing day by day. So in times to come, we have to start working and start updating our knowledge to understand and dive deeper in the issues they face so that we can give the quality of treatment they deserve. They come with their challenges, but they do come with their unique strengths. Have you heard of a child or an adult with Down syndrome who has created a Guinness Book of World Record? They're there. Have you heard of an adult who has been enrolled in a law school? It's there. They are the real stories. And they are made possible because inclusion was placed at the geographical location where they come from. In our textbooks, in our undergrad and postgrad textbook, we read what are the obvious dental issues. I think you can name them and you can count it on your fingers: cavities, periodontal diseases, as Dr. Baines has already discussed. Gingival overgrowth, maybe they are on medication. Early and late tooth decay, which can be influenced by the genetic factors or small jaw size or the concomitant hypothyroidism, bruxism, malocclusion. The other obvious common dental problems can be high arch narrow palate, tongue tie, collapse bite, early onset periodontitis, which has already been covered by Dr. Baines. Now in India, I have seen that, and I know everyone will agree, dental care is the most neglected. Isn't it so? It's so globally also. It is said that half of world's population still suffer from untreated dental disease. Millions and billions of people all over the world have untreated periodontal diseases. They have tooth loss, they have cavities. Then imagine the burden of dental problems in children and adults on neurodivergent spectrum. The rate and severity of periodontal disease, cavities, tooth missing adds on to their burden of medical condition which they are already carrying and affects their nutrition and overall quality of life. So I'm again feel proud to be associated with Kgmu and Dr. Baines and Dr. Rhythm, because we had done this pioneering study on the oral health care in children with Down syndrome. And this is first kind of study from the Indian population. Otherwise, we keep borrowing the studies from other nations and abroad. It showed that what we didn't see. This was the study, this was done, the form was given, online form was given to the parents, and parent noticed what we missed. There were swollen gums. There was loss of nutrition. Children who went to school and therapy, they had to stay at home because of the dental problem. They had anxieties kicking in. They had behavior issues kicking in. And these are something I really want you to pay attention to, because sometimes just in the rush of time, or maybe, thinking that our job is only really limited to treating the cavities or the gum problem. No. Our job is to rehabilitate the person and the best quality of life they deserve. So I say look beyond. Why? Because I see what our brain is trained for, what our brain knows. If our brain knows, if we know that we can look for sleep apnea, we can look for speech-related issues, we can look for TMJ issues in such children because of hypertonicity, and the TMJ has to work against gravity. So TMJ issues are very rampant. Mouth breathing, open mouth condition because of the bite-related issues, because of the low hypertonicity of the lip muscles and the cheek muscles. Deteriorating periodontal condition. My dear friends, Down syndrome, autism, they don't cease in the childhood. They continue throughout the life. So the continuous support for the periodontal condition, as highlighted by Dr. Vivek in his presentation, is a must. They may not lose teeth because of cavities, but they may become edentulous at an age of 40 because of the periodontal disease. So something we have to look beyond. Continued attrition of teeth because of bruxism, which was never taken care when the child was small. It became a behavioral habit, and now it is difficult to make the child come out of that habit. It led to sensitivity of teeth, and the child eventually became a picky eater or landed up with lot of sensitivities to the texture of the food. Again, data from our study, which the parent noticed that they had this lack of focus and they had difficulty in chewing, loss of nutrition, mood swings. One trigger, and it can lead to multiple response. That is why we say they are neurodiverse, because the response may not be proportionate to the stimulus given to the child or an adult. I call upon you as dental professional. Maybe you are a pedodontist, maybe you are an orthodontist, maybe you are a general surgeon, that we need to hold our hands together to give that quality of treatment and work on these issues so that we can give them quality of life. We can provide them better speech, sleep, reduction of oral sensitivity, provide them the basic orofacial muscular function and the oromotor skills of blowing, spitting, chewing, and much more. Now, we have all heard that they are sensitive, or there are so many barriers. What are these hidden barriers and how to overcome them one by one? The maximum 90% we face the barriers, they come under two headings: sensory sensitivity and the communication differences, though there are other also. What is sensory sensitivity? I don't like something. For me, I don't like apricot. It gives me some jittery feeling. I can't even stand the sight of it. But is it affecting my life? Is it affecting my daily routine? No. The sensory sensitivity, when it starts affecting their daily routine, I don't want to brush my teeth because the bristles of the toothbrush, they hurt and feel like a needle in my mouth. Is it affecting their daily routine? Yes or no? Yes? Yeah? Are you all feeling sleepy? Don't be. Don't be, because we have so much to learn, right? And I think mine's the last. Then you can relax. So sensitivity can kick in when their home care regime is in place, where they don't want to touch the brush or they don't want to use the paste. Or it can be dental office based, where they run away from the sounds and the lights or the clinical settings of a dental clinic. So as I've already discussed, it impacts their life. That is why the sensory sensitivity is of utmost importance. They may have dietary habits which may not be conducive for their overall, providing them overall health. They may have preference to soft diet. And it can be two types. It can be because of their oral issues. They already have some cavity, some periodontal problem. That's why this sensitivity has kicked in. Or maybe it is already, it's there. The sensory integration was not in place when they were in 0 to 5 years of age. It definitely will increase the risk of dental problems. So medicated side effects can lead to dry mouth conditions or gum problems. Communication and behavioral challenges. Yes, most of the time, such children and adults may be non-verbal. So picture exchange, very simple, clear instruction, 2-word and 3-word instruction works wonder for them. Ask the caregiver what are their stressors and what are their behavior facilitators or modifications we can do in the dental clinic. So always be mindful what are their stressors, because once the sensory sensitivity kicks in, it comes, we cannot do anything. So what we have to work, we have only a window period when that sensory overload, before that sensory overload, you have that window period where you can work with your patient. Very important. Is it the responsibility of only one section of dentists to take care of special need? I say no. It's a cumulative responsibility of each and every dental practitioner, whether you're working in the capacity of a pedodontist or a general dentist or a prosthodontist or an orthodontist. And we need to build that empathic attitude, because we are living in a society, and the neurodivergence is also providing a shade in the beautiful fabric of our society. So we need to weave them in. Lack of dental prevention has already been discussed, and it has seen that almost 26% of the children or adult, they went to the dentist after 7 years of age, and 23% did not even see the dentist. So lack of early dental intervention in place aggravated the dental issues in them. Anxiety and phobia related to dental problem. Most of the time we say that they don't understand. They will not understand when we forcefully they do their treatment, but they understand. They have that highlighted EQ, emotional quotient. So the anxiety and the phobia of the parents and the children, which they are carrying from the previous dental experience, can also become a hurdle. Lack of priority among parents, they are already burdened with a lot of medical condition, and therefore the dental health or the dental care takes a backseat. How can we unlock the barriers? This was the youngest patient we saw from Meghalaya. Patient traveled all the way from Meghalaya because we spoke about early dental intervention on so many forums, and the patient is still in touch. Online, they take the consultation and all. This is what we want, that hand-holding. We need to hand-hold the caregivers from the very beginning. Before treating a neurodiverse individual, we need to hand-hold the caregiver. We need to understand the anxieties they have built in within them. We need to understand from which mindset they have come, because sometimes it reflects the mindset of the family also towards the dental care and the need of the child. You already have one B.E.S.T, building essential skills through training. I'm giving you another B.E.S.T. Be informed. So symposium like this are actually very enlightening. I remember my times when things never existed like this. Things were never in place. We did not know what a special need child is. We never knew what a neurodivergent people they are. We only knew people who are on wheelchair or whose one limb is not there or one sense is not working. You are really blessed that such symposium are happening in your such esteemed premises. Be informed. The information is the basis for building your capacity and your skill. We did this one workshop in Asia's largest institute, Safdarjung Hospital, where we trained the undergrad, the junior residents and the senior residents about the dental care of neurodivergent. The very important part I want to discuss is EQ. We are not talking about IQ. Because I know that when we try to connect with IQ with them, that will never happen. As in one of the presentation, I think Dr. Pawan said they have a very high sense of social bonding. Sense of social bonding, warmth, embrace, friendliness, what all it reflects. They have high emotional quotient. It may be not in place. It may have taken some form of behavior, untamed behavior, but we can redirect. And from here, my presentation shifts from neurodiversity to neuroplasticity. When we recognize that hidden potential each brain has, and with repeated, simple, small instructions or with visual clues, we can brain train our children and adults on neurodivergent spectrum to get the desired results we as dentists want in the dental clinic setting and caregivers want in the home care setting. We have all heard of so many intelligence theory. This is my basis. Gardner's emotional intelligence theory. It works on multiple intelligence. It has nothing to do with solving the puzzles. It says you can connect with an individual who has auditory intelligence. You can connect with an individual who has kinesthetic intelligence. You can connect with an individual who has visual intelligence. And that's why the role of visual reminders, calendars, the role of bringing in their favorite toys and music and playing it in the background in the dental setting comes. These are the various ways through which we can communicate. We can establish, we can have that ice-breaking session with the person, and we harp on the biggest strength of that individual. So the treatment for each and every individual is tailor-made. It is never one size fit solution for all the neurodiverse condition or for different individual in the same neurodiverse spectrum. Schedule appropriately. We have already, in some presentation, they showed that schedule the child in the morning when you are also fresh and the child is also fresh. Sometimes the child takes medicines in the morning and child may not be comfortable in the morning. So you have to take a detailed history form to understand which is the time when you can schedule the dental visit so that the child is in a very calm and composed state. Space the appointment, because most of the time the primary cause of anxiety is seeing so many strangers in the waiting area. Maybe you can give a priority to what time you should schedule so that your OPD is thin at that time and they may not get overwhelmed seeing so many people in the waiting area. Don't be restricted, be holistic. This is my takeaway message. Don't just look for cavities. Don't just look for gum problem. Don't just look for open mouth condition. Look for high arch palate. Can it be a reason for sleep apnea in children and adults? Can this be treated? Do you know that the children and adults who have sleep apnea, their cognition also decreases? Their productivity during the daytime also decreases. So we can, if we work on it holistically as a interdisciplinary, multidisciplinary approach, we can definitely increase the quality of such individuals. Creating differences, their real lives and real stories. I'm going to discuss many cases. So we started it with the birth of my child. She was born in 2011. And the maximum health condition discussed here she had. She had transient myeloproliferative disorder where she had 90% blast cell. Doctor said they are cancer cell. You have nothing. You have to just pray that she just come out of it. At one stage, it was diagnosed with acute leukemia, childhood leukemia. She has annular pancreas. She had duodenal atresia. She has 3 holes in her heart. Her spine was not straight. Her appendix was on the left side instead of right side. Multiple health issues. She was in hospital 5 years on and off. But what we did not lose was the hope, sense of hope, and the early dental intervention. Being a dentist, this I could do as a mother to her. So these are the real cases we are going to discuss. The first is Reanshi. Believe me, this case made me run from pillar to post. 10-year-old girl, she had 0 compliance in dental chair, rejected by so many dentists and technicians, even for doing an OPG, an X-ray. And she had AV fistula. This is her echo report. These are her condition of the teeth. Every tooth is cavitated. Every tooth. Child cannot speak. Child cannot eat. Child reduced, her weight reduced. Parents are very anxious. What to do now? How to do it? We have no guidelines. We have no guidance. What to do? Rejected and anxiety built in. This is her pre-op X-ray. If you can make out multiple deciduous teeth, baby teeth are still retained in the mouth. They have not been extracted. Child is 10-year-old already. Multiple cavitated teeth, multiple retained deciduous teeth, high arched palate, difficulty in chewing, restless sleep. These were our observations. We did not see only cavities and gum problem. We went beyond. Every time she used to come, we had taken the consent from her cardiologist that under SABE prophylaxis, subacute bacterial endocarditis. Prophylaxis, 1 hour before, she used to come, she used to have her medicine, and she was taken care of in the OPD setting. We can't use nitrous in this case. We cannot use laughing gas because it is contraindicated in heart conditions. Parent can't take their child under GA every time. What is the option left with us? We have to remodel her behavior. We had to take her from neurodiversity to neuroplasticity. And believe me, it took me 1 year, 365 days, 3 hours every time she used to come with us. But we are glad we did it because it not only changed her oral health or overall health, but also change the perception of society as a large for neurodivergent. So that's a picture where the extraction is being done. And the lower picture is where we are placing the, I'll go back. We were placing the palatal expansion device. So we had sent, before the patient came to our clinic, we had sent their parents a detailed counseling form where they had to enter each and every detail. Her stressors, her facilitators, her medical history, everything. This is the treatment we did. Deciduous teeth whose successors were present, we extracted them. And we retained the deciduous teeth whose successors were not present because the chewing is already limited. We can't afford to extract. This is the post-treatment X-ray, the OPG. And I want to share something. Over a year, when her sitting behavior changed, every time when she used to come, her anxiety was under control. This X-ray she got not from our clinic, but from outside. So generalization started happening. Assume they will, they can, they will. Don't presume they will not. Include them and empower the parents because they can and they will. Inclusion in our thought process happens before we include them in our workplace. These are some of the videos I want to share with all of you. These are the parents' feedback for an year. Is it okay? Can play from there? So I can ask you one question, I think, now. So if you see any child with Down syndrome, what all will you rule out first? If you remember any of Dr. Pradeep's presentation slides, what all will you rule out before you start with any dental treatment? Suppose the patient is compliant, sitting nicely in the dental chair. What will you look for before you start the dental treatment? Rule out the medical condition. And which medical condition is more common in Down syndrome? Heart condition. They may have AB stunt. They may have holes, small holes in the heart. They may have PDA. So once you rule out that or you have that echo report, you make a team. You speak to their cardiologist. Is SABE prophylaxis indicated in this? Because there are so many heart conditions where it is not indicated with new pediatric guidelines. Any invasive procedure, if SABE is included, any invasive procedure, even if it is probing the gums, because it can lead to bacteremia, it needs SABE prophylaxis. Right? So people who are neurodivergent, they may not look like us, but their heart beats the same as ours. Their mind may not work like us, but they feel the emotions like us only. You have to be a bit more patient because there are 5 videos of this patient, and then I want to know what you all understood from the videos. I'm not playing it just to get any applause or something, but I want you to understand what the parent want to say in these videos. Sorry for the technical hitch. Be patient with us, please, for 2 more minutes. So I can speak till the time videos are going on. It will take time. So this is the case of Riyanshi. Then we have one patient, Dr. Vivek showed the photograph. The patient travels from Punjab to Delhi to get the treatment. He is now 40 years old. They had a very bad dental experience because they thought that the child will not comprehend. So 5 people got hold of that adult with Down syndrome and extracted one tooth. But look at the harm it created to the dignity of the child. Child, what is the basic right of that, an adult with Down syndrome? Treat equally as you treat another neurotypical child with the same amount of dignity. That created a lot of dental phobia and anxiety in parents. Show you that.
आप करो करो
So maybe we'll start discussing the cases and we can watch the videos because they are not wanting to. The videos later on. So this is Dhruv and he is 15 years old. Mother said we want to align his teeth because he had malaligned teeth. This is her upper jaw before treatment and we gave him aligner treatment. This aligner treatment. So when we think neurodiverse, do we always think that patient will not desire more about their aesthetics and personality? They do. They are concerned about how they look. And their parents are also concerned. They also feel that when their look is appealing or their gentle, the teeth are well aligned, the child have more confidence and will be accepted and included in the society in a better way. So we gave him, after extraction of some teeth, Some teeth we were able to deliver aligner, and believe me, patient was so compliant. He adhered to his aligner wearing protocol, and you can see the result in the next. Down you can see the next, the result post-op. This is another child who came from Punjab. Even if you don't look what I have written on the side, you can see there is an open mouth condition. Child is not able to close the mouth even in the sitting posture. Leave about when he is lying. Child cannot preference soft diet because the mouth is open, mouth breathing is happening. Speech is very disturbed, not clear. This is how the child reported to us. Now, on the left, I want you to also look at the posture of the child. When the child has open mouth condition, the posture is not good. Look at how the this neck is tilted. So multiple cavitated teeth, deciduous and permanent. Congenitally missing teeth, very common in Down syndrome. High arched palate, difficult in chewing, and restless peel. This is the palatal expansion device we placed after we did the extraction and the fillings. This is the amount of expansion we have achieved. The treatment is still going on. In some months, we achieved the amount of expansion. The child is off our rapid maxillary expansion device and now only on the holding appliance so that the bony calcification happens between the two parts of the palate. Mid-treatment, look at the pictures. Child is able to close the mouth. Yes, we provided him essential myofunctional therapy support. Look at the posture of the child now. Don't you think the parents and the child will be more confident because the posture is straight? Eye contact is improving. Speech is improving because now the child is confident. When we are a bit less confident, we try to slur our speech also. Another child, Vivan, coming from Jaipur. Again, the same condition, periodontal and cavitated teeth. High arch palate, difficulty in chewing, restless sleep. This is the sleep study. So when we started doing the palatal expansion, we did not do sleep study for some of the patients. But later on, we formed a team with pulmonologist, ENT, and everything nowadays is in place. All the records in place. So whenever you treat a child or an adult with sleep apnea, one is you can go for sleep study. The other is airway volume analysis, which is the EKG that you can opt for. This, he has a facial mask also because his jaw is slanting upward. So we have to bring it down. So along with the palatal expansion, he has another facial mask in place. Look at the change in the profile of this child. Closed mouth condition, no straining on the lips and the posture. Krishiv is on autism. He had a very bad dental experience, had to undergo extraction of one tooth. Again, he was held forcibly by 4 people just to get one tooth extracted. And that created a lot of phobia in child and the parents' mind. We had to take this patient under GA. We treated him completely under GA. The root canals were done, pulpotomies were done, fillings were done, cleaning was done. preventive fillings, put and fissure sealants were done. But did we let the child go? No. Handhold the child. It's been 2 years. Krishiv is coming regularly to our dental clinic. There is a feedback of mother also. He came to our clinic with a new cavity. Won't believe he got the treatment in OPD setting. We did not need him to put him under laughing gas, actually. Recently, when his mother was speaking with my front desk manager to reschedule his appointment, one staff member took him to OPG and he got the X-ray done. To her mother's surprise, she didn't know that he's getting the X-ray done. This is the power of neurodiversity, changing to neuroplasticity. This is the power of believing that they can, they will do. They can see both the X-rays, pre and the post, with root canals in place. I think we will not be able to play this also.
Hi, my name
This is the adult with Down syndrome who was present in India International Down Syndrome Conference, and we clicked with him. He again came from Punjab. Poor previous dental experience and multiple cavities. Now look, we did not ask him to rinse his mouth before sitting in the dental chair. Reason why? Because there's a poor oral motor control. The muscles of the tongue may not go and clean between. This is the amount of food remnant remaining in the mouth, and they may not be able to sense it. The amount of cavities, every tooth is cavitated. We robbed in the caregiver. Caregiver is the bridge between me and the child or the individual. So we have to take their help every time. Nishtha is an adult with Down syndrome. We could not do early rapid maxillary expansion because the sutures were already, mid-palatal suture was already fused. She had moderate obstructive sleep apnea. This is the profile and the front picture. This is how her bite was, scissor bite. All the teeth of the upper jaw inside the lower jaw, right? Collapse bite. Upper high arch palate. We had her sleep study. She was advised CPAP. Difficulty in chewing food, very obvious. Restless sleep, very obvious. We got this MARP. So this was digitally designed for her. This technology had not been in India. Only just, I think, last year. Only this technique has come where they do the digital printing and 3D scanning we do, and then this device comes, which is customized. Place the mini screws. Can you see the splitting of the suture? Worked at an age of 24. Look how her bite is expanding, the upper jaw expanding. From the scissor bite, now she has come on an edge-to-edge bite. Kasak, she was 10-year-old when she came to us. Now she's 12 years old. Again, multiple cavitated teeth. In this case, parent didn't have any anxiety. Child had. Parent did not have any anxiety. Child had. Role reversal. We had to do something which we didn't do before, because at mostly 90% the parents carry the anxiety which is gone to the child. And this Parent didn't have any anxiety, only the child had. And we had to really handhold the child so nicely that she got all her cavitated teeth done. And we had done the maxillary expansion also in this case. Once your child is compliant, when the child listens to you, you can give them the number of treatment they need. You can definitely bring a drastic shift in their oral care, the quality of life, everything. These are some adult cases with autism we have done under GA, under our Smile Special Foundation. This is a patient, this is actually both the parents are doctors, and he is an adult with autism, and because they had only 2 days with us, so we had to take the case under GA. Over these years, when my daughter was born, and now in 2025, we have done a lot of awareness camps. We have authored a book, co-authored another book with Indian Academics of Pediatrics. We have seen more than 200 children and adults with Down syndrome and treated them in our dental OPD. Able to hold some workshops and webinars even with the international organization like International Asia Pacific Down Syndrome Association. Spreading awareness even to schools, even to organizations like Action for Autism or India Autism Center, going there, hand-holding them, and doing whatever is in our capacity and capability. This is the book we had authored and presented to Dr. Chona, very eminent personality working in special needs sphere, ex-dentist, dentist to ex-president Dr. Gautam Khatak, Dr. Ruchika, HOD Maulana Azad, Conservative Department, MBN School Head, Ma'am, and Sanskriti School Head. This is the IAPA endorsed book on Down syndrome where we have contributed, me and my husband. For the past decade, I have learned from my patients, it is not what you have done, or it is basically how you made them feel, how you connected with them emotionally. That makes the difference in their lives. I tried to convert my pain into passion. Those years of sorrow and, crying into something which I can turn into a sense of hope and empowerment to my fellow dental community and to all the special need parents who have been going through all these ups and downs in their life. Give your best. You have the best. Give your best because they deserve the best. And in the end, I would like to say, see the ability, not the disability, and together we can, together we will. She is my child, Ashi. She's 14 now. And this is her brother, Abhyuday. He's 4 years. Thank you for your time and patience. Thank you. Thanks a lot. If you have any question, please do ask. Don't be restricted. If you have any question related to any case, please do discuss. I'm open to all kind of questions. Can we play the videos now? Yeah.
Kindly stay seated. After this, the JR1s of PEDO department. After this, the JR1 of PEDO department have a skit prepared for all of you. Kindly stay seated. So all the postgraduate students of pediatric and preventive dentistry, please come forward. We will take some time to make arrangements on the dais. In the meanwhile, the video is playing.
Hi, my name is Juhi Menon, and I'm the mother of an autistic child. His name is Krishiv Menon. He's 12 years old. तो उसको एक्चुअली काफ़ी सारी डेंटल प्रॉब्लम्स थी, मतलब कैविटीज़ एंड एक दो टीथ तो बिल्कुल ही खराब थे उसके। तो व्हाट हैपेंड वाज शुरू में हम उसको एक डेंटिस्ट के पास ले गए द्वारका में, एंड ही इज़ अ स्पेशल चाइल्ड, तो हमें एक्चुअली पता नहीं था कि क्या करना है। तो द डेंटिस्ट सॉ हिम एंड शी सेड कि एक टूथ हमें एक्सट्रैक्ट करना पड़ेगा, बिल्कुल ख़राब है। सो ही वॉज नॉट कोऑपरेटिंग। तो द डेंटिस्ट देयर शी सेड कि ये तो करना ही पड़ेगा कैसे भी। तो देन हुआ ये कि इट वॉज अ मिस्टेक वी डिड, बट उन्होंने उसको पकड़ के 3-4 जनों ने एंड दे फोर्स्ड हिज माउथ ओपन एंड वो जैसे तैसे किया। इट वाज वेरी ट्रॉमेटिक एक्सपीरियंस। तो एक्चुअली हमें पता नहीं था, इसलिए वी वेंट फॉर इट। एंड देन उसके बाद वो हुआ, दैट टूथ गॉट एक्सट्रैक्टेड, लेकिन और भी बड़ी सारी प्रॉब्लम्स थी। एक टीथ और भी खराब था, इट नीडेड अ रूट कैनाल, कैविटीज भी थी। तो देन वी डिडंट नो व्हाट टू डू। तो देन समबडी टोल्ड अस, हमारा एक पेरेंट्स व्हाट्सएप ग्रुप है, समबडी टोल्ड अस अबाउट डॉक्टर निधि एंड डॉक्टर अनुराग। तो फिर हम उनके क्लिनिक में आए, एंड देन दे एक्सप्लेन लाइक बिकॉज ऑफ हिज फियर ही वाज नॉट कोऑपरेटिंग हेयर आल्सो, क्योंकि उसके अंदर इतना फियर भर गया था। सो देन वी डिसाइडेड टू गो फॉर जीए। और जीए में डॉक्टर निधि एंड डॉक्टर अनुराग ने काफ़ी इसके साथ मेहनत की, अराउंड 4-5 आवर्स, एंड सारा कुछ मतलब एक ही बार में इट गॉट ओके। एंड उसके बाद से देयर हैज बीन नो प्रॉब्लम, एंड ही इज एबल टू ईट ऑल काइंड्स ऑफ फूड, मतलब रोटी, राइस, एवरीथिंग। तो उसका न्यूट्रिशन वाला जो प्रॉब्लम था वो सब ठीक है, जो कि पहले नहीं खा पाता था। नाउ ही कैन ईट एवरीथिंग। एंड मतलब अगर हमें पहले पता होता तो वी वुड हैव कम हियर ओनली। तो
Thank you very much, ma'am, for your insightful keynote address. Now I request Dr. Pramila Verma, ma'am, to kindly come forward and felicitate our chairpersons for this session, Dr. Gaurav Jain and Dr. Pooja.
हेलो, मेरा नाम सुधी है और मैं 37 ईयर्स की हूँ। मेरी डॉटर है, 11 साल की हो गई है। इसका ये डाउन सिंड्रोम बेबी है और इसका यहाँ पे हम लोग 1 साल से फॉलो कर रहे हैं। पहले इसके दांत जैसे टेढ़े मेढ़े थे, प्लस सबसे बड़ी प्रॉब्लम थी कि खराटा लेती थी। खराटे लेके रात को सोना, मुंह खोल के सोना, ये प्रॉब्लम था। तो डॉक्टर अनुराग ने हमें सजेस्ट किया था जॉ एक्सपेंशन का, क्योंकि इसके जॉ भी काफ़ी ज़्यादा वाइड थे। तो फिर उन्होंने अभी जॉ एक्सपेंशन अराउंड 8 to 9 मंथ से चल रहा है और अभी इसको काफ़ी ज़्यादा इम्प्रूवमेंट है। ना सिर्फ स्पीच में, सबसे इम्पोर्टेंट चीज़ कि अब ये मुंह खोल के नहीं सोती है, और इसका
I also
खराटे
request
लेना
Dr. Pramila Verma, ma'am, to felicitate our keynote speaker, Dr.
मालूम पड़ता है
Nitya, ma'am.
काफ़ी ज़्यादा खुल गया है, तो बहुत ज़्यादा बक बक भी करने लगी है अब तो, बहुत ज़्यादा। तो अगर किसी भी पेरेंट्स को लगता है कि उसके बेबी में इस तरह की प्रॉब्लम है, वो मुंह नहीं खोल पा रहे हैं या टंग बाहर बहुत ज़्यादा आ रहा है, तो एक बार ज़रूर उनको ये चीज़ें करना चाहिए, जो एक्सपेंशन करवाना ही चाहिए, स्पेशल फॉर डाउन सिंड्रोम बच्चों के लिए. सो थैंक यू सो मच डॉक्टर अनुराग एंड
कैमरा देख रहे हैं हमारा
Now I request Dr. Richa ma'am to kindly come forward and take over the proceedings for the role play.
Thank you, Dr. Muskan. I request everyone to be please seated so that we can start with the role play. So this session, myself, I'm Dr. Richa Khanna, a professor, Department of Pediatric Dentistry. And with me is Dr. Rameshwari Singhal, professor in Department of Periodontology. So we present before you on behalf of the core workers of this session have been the residents of pediatric and preventive dentistry, who are going to present before you a small role play depicting what is good and what is bad, or what the do's and don'ts of dealing a special child on a dental chair. So I now call upon Dr. Poonam Shukla, who would take further the role play from here.
कौन सी है? ये होगी. ऑन करो बस. ये शेयर करनी है ना, ये शेयर करनी है. भाई माइक दो तुम. दो माइक हमने वहां रखे हुए हैं, दे रहा हूँ ये. यहाँ से ऑन ऑफ होगा. कौन लेगा कॉल पे? जिसको देख लगाओ, इनको लगाओ.
कौन सी माइक?
ऑन ऑफ ऑन ऑफ ऑन ऑफ ऑफ.
We are going there.
Good afternoon, everyone. Today, I, Dr. Poonam Shukla, and I, Dr. Shagun Rana, resident of Department of Pediatric and Preventive Dentistry, Kgmu, are here as narrators for today's play, The Courtroom of the Child. And we are here to explore one of the most delicate challenges in dentistry, and that is behavior management. Every child who walks into the dental clinic carries not just teeth to be treated, but also feelings, fears, and trust to be protected. Through this courtroom drama, we will witness two very different dentists. One who mishandles behavior and loses the child trust, and another who wins it through patience, empathy, and science. But today, our story goes a step further. We focus on a special child, one with unique needs, abilities, and challenges. Children with conditions such as Down syndrome and ADHD often process the world very differently. They may require extra time, gentle communication, and a supportive environment. Their dental visit is not just a treatment, but a test of society's compassion. And as dentists and human beings, it is our duty to adapt, to make care inclusive and to ensure that no child feels left out. When we bring patience, creativity, and respect into our clinic, we are not just treating a teach child, we are shaping a more accepting and empathetic world. My role today is to guide you through the scenes to point out what goes wrong, what goes right, and why the child's mind, the true judge, always gives the final verdict. So now I'll introduce you the characters of drama, the courtroom of the child. And the characters are, we have Dr. Amrish as judge, symbolizing the child's mind. We have Dr. Mansi as prosecutor of fear, bad behavior management. We have Dr. Tambra as dentist, who is advocate of trust, good behavior management. We have Dr. Kiran, who is dental assistant. We have Dr. Shahina, who is playing child with Down syndrome, silent but expressive, and parent who is a witness of all this. Act 1, the court opens. And the judge walks in. All rise.
This courtroom of the child's mind is now in session. So today we'll hear the case of behavior management in dentistry, where the fate of trust or fear will be decided. The child will be the silent jury, and every action of the dentist will stand trial, and let this trial reveal the truth. Dentist 1, you present your approach.
Act 1, Scene 1, the waiting room. And the characters here are Judge, Dr. Tambra as parent, Dr. Shaina as child, Dr. Mansi as dentist, and Dr. Kiran as assistant.
Good morning, ma'am. Good morning. Call the patient. Yes, ma'am. Come, sit on the chair. Come. We don't have whole day for you. Come and sit.
Notice the first trigger, rushing the child without greeting. Children with Down syndrome needs extra time to adjust. But here, the dentist shows no patience, no eye contact, and no warmth. Act 1, Scene 2, the dental chair.
Open your mouth. Open your mouth. Open your mouth. Open your mouth. Open your mouth.
Ma'am, she is not cooperating. Let's do it forcefully.
Okay, hold her hands. Open your mouth.
Notice the second trigger. Loud voice,
Sit
bright
properly.
light,
Don't be
sudden
so stubborn.
commands, rough handling, and mocking the child can only increase the anxiety and fear in these patients. As physical force is one of the strongest trigger, leading to immediate resistance and fear. Act 1, Scene 3, communication breakdown. Ma'am, she is getting afraid. Can we do it slowly, please?
Ma'am, we know our work better. Please stop interfering. Open your mouth. Big mouth.
Ma'am, but she needs some time.
Ma'am, you go outside and wait. Ma'am, please go outside. No. Keep your hands here. Ma'am, please go outside and wait.
Did you notice another trigger? That is exclusion of the parent.
Stop.
For a child with the Down syndrome, the parent is the anchor of security, and removing the support makes the cooperation almost impossible. Act 1, Scene 4, the wrong ending.
we can't perform treatment like this. Call her parent, inform them that they may have to understand and bring tomorrow. We can't perform like this.
And so, the appointment ends in tears, fear, and mistrust. This isn't just a poor behavior management, it's a breach of compassion. What could have been an opportunity to build trust became a moment of trauma. Act 1, Scene 5, the courtroom.
Okay, so now this is all about the first case. Dentist 2, you present your approach.
Starting with Act 2, the characters are Dentist 2, played by Dr. Itambara, Parent, played by Dr. Mansi, Child with Down syndrome, played by Dr. Shahina, Assistant, played by Dr. Kiran. Act 2, Scene 1, a gentle beginning. Parent and child are sitting in the waiting area. Dentist enters, not in a hurry, but with a colorful toy in one hand.
Hi, Sophie. How are you? See?
This is Jojo.
You like the toy? Okay, we have a room full of toys. You want to see the room? Okay, come, baby. Come, come.
Children with Down syndrome often understand the world better through play, warmth, and trust. Did you notice the calming strategy the dentist used? She began not with tools, but with a toy. Act 2, Scene 2, Building Trust. Dentist lowers the chair slowly, lets the child touch buttons, and familiarize themselves with the operatory environment.
Sophie, see, we have this magical chair. It will go up when we press the button. See how it's going up. You want to sit on this chair? Okay, let your toy first sit. Now you want to press the button? See how it's going? Very good, Sophie. Very good. Now you want to sit? Come, baby.
Instead of rushing, the dentist invites the child to explore. Control builds confidence. Meeting the child where they are builds connection. Act 2, Scene 3, Tell, Show, Do.
Sophie, see, we have a magical mirror. It will show all the monster who is sitting on your tooth. Can I check yours? Okay, first we'll check your toy's teeth. See, he's smiling. Nothing happens to him. You like it? Now can I check yours? Open your mouth, baby. Very good, Sophie. You're doing very great.
Very good, Sophie.
Notice how the dentist uses tell, show, do and turns fear into curiosity. By letting the child touch and see instruments before use, she turns the unknown into familiar. Act 2, Scene 4, Parental Involvement. Child looks uncertain. Parent gently holds the child's hand. Relax, Sophie. You are doing it very great. Please open your mouth, big mouth. Show the dentist. Open your mouth.
Sophie, your mama is here.
Nice.
You're doing very great, Babu.
Nice.
Very good, Sophie.
Very good.
We are proud of you. When dealing with a child with Down syndrome, parents are partners. Children often rely on familiar support. Tell, show, do, positive reinforcement, and parental involvement all are recommended by AAPD. Act 2, Scene 5, a positive ending.
Sophie, you did very well. Now we'll give you gifts. Which sticker you want? This one? Okay.
Can I place it on your hand? See? You like it?
Very good, Sophie. And that's how a simple appointment becomes a moment of trust, joy, and success. With patience, creativity, and respect, we don't just treat teeth, we build confidence. Act 2, final scene, courtroom. The verdict, all rise.
So, we hear the case of behavior management in dentistry. This was not an ordinary courtroom. The child was the witness, jury, and the truth itself. Dentist 1, the prosecutor of fear. Dentist 2, the advocate of trust. The verdict is very clear. The dentist who earns my trust, not by force, but by compassion, wins. So I choose dentist 2. For in the child's heart, the final judgment is already written, not in our words, but in what remains behind trauma or confidence. The court is adjourned.
The lesson to take home. Children with Down syndrome need patience, positive reinforcement, simple communication, and parental involvement. A gentle smile, slow introduction of instruments, and respect for the child's pace make all the difference. Wrong management does not just fail the treatment, it fails the child. Every child is the judge of your behavior, so choose wisely. Thank you.
¡Ay, caramba! बैठ के हमको मक्खी नहीं मारना हर दाव जीतेंगे हम आका हमको नहीं हारना हम हुकुम के इक्के हैं सुबह के पक्के हम हुकुम के इक्के सुबह के पक्के खा के थपेड़े चौड़े से टेढ़े बने हैं तो हम क्या करेंगे अम्बा
Thank you, everyone. That was indeed a very engaging and insightful role play. We'll now take a short lunch break for half an hour. Please rejoin us after the lunch break for the hands-on skill stations. Please join us after the lunch break for the valedictory function. The lunch is held at room number 106.
Big congratulations to her. Second prize in undergraduate category, again an online participant, Pavni Prashant Kenthola, KLE Institute of Dental Sciences. Their posters are displayed in print form also outside. And first prize in undergraduate category, any guesses? You will not have because nobody has seen the posters. So the first prize, it goes to Jagriti Patel from BBD Cords, Lucknow. Is she here? Or any student from BBD Cords? If they can take her, if they can take the certificate on her behalf. A big round of applause for Jagriti Patel. Keep clapping, please. Now we had 3 themes. First theme was designing a clinic for special needs patient. Second theme was empathy. And third theme was special care for special needs patients. So theme-wise, there are no first or second. Theme-wise, 2 posters have been selected. First is Samarth Singh from King George's Medical University. Come forward, please. And second is Aditi Rajesh Sawant and Aditya Kajla from KLE Institute of Dental Sciences. KLE Institute participants had submitted very beautiful hand-drawn posters. Now, second theme is empathy. And first prize goes to Tanu Singh, Saraswati Dental College. Is she here? Or anybody on her behalf? And second winner in empathy theme is Navya Mehrotra and Vishakha Singh, King George's Medical University. Third theme was special care for special needs patients. And 2 posters have been selected. First is Sujut Fatima, Saraswati Dental College. And second winner is an online submission from Khushali R. Goswami, College of Dental Sciences, Bhavnagar, Gujarat. Now moving on to the PG prizes. In postgraduate category, first I will announce the overall prizes. I will start with the third place. The third prize goes to Dr. Prajwal Srivastav and Dr. Avni Barnwal, Saraswati Dental College, Lucknow. Second prize was an online submission by Dr. Roshni Subedi from NAMS Medical College, Nepal, Kathmandu, Nepal. A big round of applause for her. And first prize was also an online submission by Dr. Ahana Sharma from Santosh Dental College. Dr. Ahana Sharma very beautifully presented the barriers which are there for the special needs patients, and they have copyrighted a comprehensive guide for the guidelines for the barriers and challenges and how to manage them for the special needs patients, and it had been granted a copyright. So they deserve the first prize. Now coming to theme-wise announcements, there were 3 themes. First theme was interdisciplinary management of dental special needs patients. Second theme was barriers to oral health in such patients. And third theme was oral health challenges from childhood to adulthood. So for the interdisciplinary, the first poster is from Major Tushar Bhargav, Army R&R College, New Delhi. Second winner in interdisciplinary theme, Dr. Meenu Kara from Saraswati Dental College, Lucknow. Anyone from Saraswati Dental College? She's there? Acha, she's the winner. Congratulations. Second theme, barriers to oral health. First poster announced was an online submission by Dr. Bhavleen Kaur and Dr. Anjali Puri from GDC Amritsar. Second poster selected for this theme, Dr. Sharanya from King George's Medical University. Dr. Sharanya very well presented the narrative review in her poster. Third theme was oral health challenges from childhood to adulthood. Two posters have been selected. First is Dr. Arun Singh and Dr. Abhinya from King George's Medical University. And the second poster selected is by Dr. Tanvi Prashant Pimpale, Saraswati Dental College, Lucknow. So many congratulations to all the winners and their guides. And a big thank you to all the participants for taking part in the poster competition so enthusiastically. Thank you so much. The periodontics JR1s are here. Please come forward. There's a special prize for you by Dr. Pramila Verma, HOD, Conservative Dentistry and Endodontics, a special cash prize for you by the scientific coordinator. A cash prize of rupees 1100 for the team. A big round of applause. They very well presented the barriers in communication and the ways to overcome them when you are treating a special need patient. So thank you all. Thank you so much for being here with us. And thank you all the online participants who are here with us, listening to us. And it was a challenge to conduct it in the hybrid format, but we did it. And I hope we did it well. We will send a feedback form to you, a Google form to all the participants. And please give your genuine, honest, critical feedback. We need it to improve it. A special thanks to all the colleges who had got their participant registered online, offline both. Special mention to Colonel Bhagbati, the Research and Referral Institute, New Delhi, for getting all their postgraduate residents so enthusiastically they participated and they very well acknowledged the topic and they were very willing to be a part of it. Thank you so much, one and all. Thank you.
Thank you, all of you, for this August gathering here. And for this workshop, I would like to thank Dr. Rhythm, who has worked so hard, and my residents who have worked so hard. And the thought she has, the concept which she has taken is very innovative. And we would also like to that go further in this reason. So thank you all of you for this. And 3 cheers for Dr. Rhythm.